Good morning, everybody, and thank you for joining us today for the Kentucky School Kickoff event. Give me just a second. I'm going to share my screen here and we'll get started. All right, my name is Nikki Millward, and I'll be one of your hosts today. So just a few housekeeping items before we get started today. This session is a webinar. All attendees are muted and videos are off. Please use the Q&A box for any questions you might have today. We will have ASL interpreters with us on the screen today throughout the session. We appreciate your patience and grace for any technical difficulties we encountered today. The session is being recorded and will be available for viewing at a later date. To be eligible for your CEU certificates or your certificate of attendance, you must be present for at least 90% of the session today. We use Zoom to track those meeting minutes for us. You can use the same, please make sure that you've used the same email that you registered with to join the session with today so we could track your attendance. At the end of today's session, you'll learn more about how you receive communication from us about the CEU process, how to complete the session evaluation, and how to access your online certificate. So for today's agenda, we're going to start off with some opening remarks from Secretary Freelander and Commissioner Marks, and we'll go right into our presentations. The first one is Turning Crisis into Opportunity, New Pathways to Successful Outcomes in Addiction Treatment. That's going to be from our Bridge team panel with us today. Then we'll go into Recovery Capital, Assets, Not Abstinence from Dr. Elswick. Then we're going to have a little treat today with our virtual award presentation by Mike Berry. And then we're going to wrap up with those CEU instructions about how we complete those and then review some upcoming Kentucky School training sessions. Kentucky School is administered through the Department of Behavioral Health, Developmental and Intellectual Disabilities. And since it's been a little bit since we've been in front of you all, we just wanted to share some updated mission and vision and values with you today. So our mission is to promote health and well-being by facilitating recovery for people whose lives have been affected by mental illness and substance use, supporting people with intellectual or developmental disabilities, and building resilience for all. And of course, our vision is that all Kentuckians have access to quality services and supports to live full and healthy lives. And you can see our core values there listed at the bottom of the screen. So as I said, I'm one of your co-hosts today. My name is Nikki Millward. I'm the Assistant Director for the Division of Substance Use Disorder. And I will pass it off to our other co-host today, which is Dr. Brittany Allen, our Director. Dr. Allen.
Thanks so much, Nikki, and good morning, everyone. So wonderful to have so many folks joining us. I do see a couple of folks have their hands up. If you want to just put any questions you may have in the Q&A, we will sure aim to get to those as quickly as we can. As Nikki mentioned, we are with the Department of Behavioral Health, Developmental and Intellectual Disabilities, specifically our Division of Substance Use Disorder. So as you all may recall, we used to previously be the Division of Behavioral Health, but we have reorganized into a Division of Mental Health and a Division of Substance Use Disorder, simply because we have so many incredible initiatives and programs that we are implementing at this time that we just needed to divvy up that capacity and increase our capacity to do the incredible work that we're doing with our community partners throughout the state. So again, thank you, Nikki, for the intro, and thank you again for all of your hard work. She's been the one, of course, emailing everyone and making sure everyone has the correct links to get into today's event. But we are so excited about the relaunch of Kentucky School, which for nearly 50 years has been a staple training event in our state and really throughout our region for human service professionals across the state, across local organizations that serve individuals impacted by substance use disorder and co-occurring mental health. It's provided an optimal opportunity to learn and innovate, exchange best practice, network, and collaborate across community partners. And it's been on hold for far too long, which is why we are so pleased to bring you all the Kentucky School Virtual Learning Series, to bring this to life, especially during Recovery Month. And we appreciate each and every one of you for joining us today, and also for joining us for any subsequent virtual learning opportunities. And please know that we do look forward to bringing back in-person Kentucky School in the near future. So stay tuned, stay engaged with Kentucky School. There is certainly more to come. Now, before we get started with today's agenda, I do want to turn it over to some of our cabinet leadership for some welcome remarks. So I want to start with our secretary for our cabinet for Health and Family Services, Eric Friedlander. Good morning, Secretary.
Morning, Brittany. How are you?
Very good. So good to see you this morning.
Good to see you as well, and welcome back to the Kentucky School. Excited to be back with you. It's been a while. It looks like we're heading up towards 600 folks who are going to participate. That's very exciting, and I appreciate everybody that's participating today. And I want to thank you and Commissioner Marks, you and your team, for being able to put this back on and come in a virtual manner to try something a little different than we have in the past. But I'm excited about this. This is how we embrace some of the things that we learned during COVID. Of course, that's why we haven't had the Kentucky School in a couple of years, or one of the reasons why. So happy to be back because of that. And here's the thing: we are learning to, and have learned. I think the best thing is how we support each other. Right? How we support those folks in the field, how we support our community partners. I think we've done a lot to work on what that support looks like, and how to make that real for individuals and communities that we all serve. And so being able to learn new things, I think that's really important. You saw the department's mission statement at the cabinet. We talk about lifting everybody up, lifting individuals and communities to reach their full potential. And there's another thing that we talk about, and that is, we're in Kentucky. And so we talk about y'all, right? And what we always try to say is y'all means all y'all, not a few of y'all, not some of y'all, not most of y'all, but all. And we at the cabinet, and I think we as a part of Team Kentucky, that's what we're trying to live out. It's not that we're trying to look at folks who agree or disagree or anything like that. It is that we are to be supporting every person in this state. And that means second chances, third chances, fourth chances, and learning what are those things that are most impactful. And so by you all joining us today, hearing about best practices, hearing about what we're trying to do in the field, hearing how we're trying to support community, and being able to join with us to make a difference in the communities and individuals we are all serving together, to lift them up, to lift ourselves up, to talk about resilience, to talk about self-care, all of that, as we all work together to make Kentucky a better place to live. Now, we've seen some outcomes of that. We saw it before COVID, where we were seeing some decreases in some of the substance use issues and substance use numbers and overdose deaths. We had a spike during COVID. We've seen a slight decline, which precedes a lot of other states. I hope it's going to be a challenge to keep that going. Absolutely know that. 1 year does not a trend make. But we need to make sure that we continue the good work, that we continue to support each other, that we continue to work on things together to make a difference for everyone that we're serving. And I know you all do that. I know you all believe in that, or you wouldn't be here. And so I'll leave you with this. I talk about this within the Cabinet for Health and Family Services because I believe it strongly. We talk about tying to mission. We talk about making sure that what we do is impactful and supports, again, who we are and who our communities are. But each one of us, and you all see this, when you work with folks who have substance use issues, who have behavioral health issues, you know that you have a chance to interact with any individual and make a difference in their lives. You know when sometimes that light switch comes on and that person's life is changed forever. These are things we get to wake up and think about doing every day. You all do this every day. Take pride in your work. Know that what you're doing is important, and know that what you're doing makes a difference. So thank you for making a difference for Kentucky. Thank you for making a difference for your communities. And remember to make a difference for yourself as well. And this is our way of trying to help lift you up and our communities up, to understand what best practice is, to continue to support you in making the best decisions and bringing the best information to you as we can. So thank you all. I'm going to turn this back over to Brittany.
Thank you so much, Secretary. I appreciate your thoughtfulness in your remarks this morning. There are folks on this call that are, of course, doing some life-saving work. So I appreciate you being here and taking some time away from your busy schedule to join us. And now I am going to turn it over to Commissioner Katie Marks.
Hi, good morning. Thank you so much, Secretary and Dr. Allen. It's an absolute honor as your commissioner to welcome you back to Kentucky School. We last convened in 2019, and that was our 46th annual meeting. Wow, what a tradition we are carrying forward. I was preparing my thoughts for today and reflecting on the past Kentucky schools that I've attended, and even I went back and flipped through past catalogs of our Kentucky schools. I read the past commissioners' well wishes and the names of the folks that presented and the topics of the presenters, and I was humbled. And I was also motivated by this next vision and capacity that we've grown in our state over the past 3 to 4 years. And I thought about, again, this idea that our Kentucky school has been a tradition, not just for education and training, but also for the experience of community. And so if this is your first Kentucky school, I want to welcome you to this ongoing community. As we rebuild our understanding of community and tradition, I think that we're presented with an opportunity to also reevaluate and reconceptualize the process and the product that we've put out for you. It is an absolute honor to create an infrastructure for the work that you do day in and day out. And Kentucky School is that opportunity to provide resources, community, education, training that'll help you on a day-to-day basis. I think also that this virtual platform really honors the adaptations we've all made to serve our community and clients throughout the pandemic. And it also honors that very specific benefit of telehealth, because we're breaking down the structural and systemic barriers of both distance and resource access by being here virtually today. And I think the topics we're going to present on both today and in future sessions are both timely and cutting edge. We've gathered experts. Oh, Nikki, we can see your inbox right now. We've gathered experts both locally and nationally. And I think this is how we really push our substance use disorder system of care forward. As a quick reminder, prior to this, I served as the project director for our Kentucky opioid response effort. And that was such an honor, because it was a platform to seed innovation. And we imagined and reimagined and implemented change and vision that we built out and built in harm reduction. We expanded the dialogue and acceptance of MOUD, medications for opioid use disorder, and brought it into our vocabulary. Replicated quick response teams, built a statewide anti-stigma campaign, expanded treatment access, built a multiplying cadre of recovery community centers. And why I bring up some of these specific examples is because this vision and work that so many people on this call are part of is bigger than just opioids or the overdose crisis. It is representative of our mission to increase equitable access to high quality evidence-based prevention, harm reduction, treatment, and recovery support services across the continuum of substance use disorder service and care. And so in my current role, I just am grateful and look forward to continuing to amplify your work, our work, strengthening its connection in co-occurring mental health, developmental, and intellectual disorders. I look forward to just continuing to deconstruct stigma and discrimination with you, addressing the social determinants of health that modulate substance use disorder risk, lowering barriers to services, infusing our system of care with the values of harm reduction, and supporting long-term remission and recovery, all flavors. Thanks so much. I'll turn it back over to you, Dr. Allen.
Wow, thank you so much, Commissioner. Again, appreciate both you and the Secretary for being here this morning and for offering those timely and poignant thoughts. I hope that we all can keep those words in mind as we continue through this session and of course, through our ongoing efforts to serve those in need. And I just want to highlight something the Commissioner mentioned. Kentucky School is a resource. It is a much needed resource, and it allows those of us that are serving some of the most vulnerable people throughout our Commonwealth to build and enhance the quality and accessibility of our services across the continuum of care. So again, we are very grateful to be back. And very grateful to be able to provide you all with this resource. We want to collaborate with you on that. We want to hear from you all, know what you want to learn about, know what you need to learn about as a field. So again, please continue to be plugged in with us and connect with us so we can ensure that we bring you the resources that are truly most valuable to your work. Now, without further ado, I would like to introduce our first presenters for the day. First, we have Ariana Campbell. She is a co-founder, director, and principal investigator for Bridge and the senior advisor of MOUD, Medications for Opiate Use Disorder for U.S. Acute Care Solutions. Ariana is an emergency department and addiction medicine physician assistant with over 23 years of clinical experience, who developed and implemented a groundbreaking emergency department MOUD program at Marshall Hospital in California. Dr. Jean Hearn is a board certified in emergency medicine and emergency medical services and serves as medical director for multiple emergency service agencies. Dr. Hearn's work and research are at the forefront of implementation and expansion of pre-hospital MOUD in California and around the country. Next, Dr. Alicia Gonzalez is an emergency medicine physician, and through her work as Director of Clinical Training for the Bridge program, she has been instrumental in the development of MOUD programs and improving the care of patients with substance use disorder across California and nationwide. And last but not least, Josh Luftig is an emergency department PA and co-founder of California Bridge, who has revolutionized naloxone distribution by creating one of the nation's first high-volume, low-threshold department-based naloxone distribution programs, which has helped to shape the landscape of healthcare-based harm reduction in California and across the country. We are so very excited to hear from you all today. Bridge team, take it away.
Well, thank you so much, Dr. Allen. I am so excited to be here and to have so many people who are interested in this work. I want to set the stage here. This is what we're doing. This is what we set out to do, gosh, way back in 2017, 2018, when we were trying to determine what we could do to just turn around opioid overdose deaths in California. And then I want to give you a little platform for why the emergency department, because I am still asked that all the time. And it's really this, it's turning crisis into opportunity. So this is what's really important. We already have a lot of people who are, of course, as we already mentioned, dying from opioid overdoses. And there's this great prevalence of substance use disorders in our country. So what can we do with pre-existing infrastructure and just do a better job of meeting people where they're at? And there's multiple touch points that are incredibly important, including EMS, emergency departments. We do know that a lot of people who are suffering from the effects of their substance use disorders access, EMS, emergency departments, and how can we innovate those areas to provide better care so that people have opportunities for recovery, opportunity to get life-saving medication. So next slide. The program in California was supported by the Department of Healthcare Services, but we are a program of the Public Health Institute. So none of us have any disclosures here. We are all working. This is grant-funded, mission-driven work. We really, truly care about what we're doing. We have a grant from the FOR Foundation, the Foundation for Opioid Response Efforts, so we can do national work. Because what we were doing in California has been it's been so impactful that we want to share what we're doing with the rest of the country. And really what we want is every state, every emergency department, every EMS organization, everybody to adopt these evidence-based practices so that people get the care that they need and deserve. All right, next slide. So this is my team. I'm so excited. You have all these all-stars here today. And so we're going to go through different sections. So we'll talk about EMS, and we'll go through just the emergency department. We're also going to address harm reduction. And there's something, I'm hoping so everybody here can get something out of this that they can carry into their practice, into what they do every day. All right, next slide. So this is the thing. We thought in the beginning, there's a small group of our founders. So Josh is here today, both myself, Amy Moulin, Andrew Herring. We sat down and we tried to figure out how we could have the greatest impact in the shortest period of time. We know time is overdose deaths. So if we take too long to make a difference, then there's more people dying. So we really felt this urgency to create a system of care that works for people who use drugs. So what we did find is that when we did this, so this is just, I'm starting with the spoiler alert, it worked by doing this in the emergency department. So what we found is that when we were able to innovate the emergency department to provide specifically buprenorphine treatment and place substance use navigators. So a lot of different states have utilized, some of the opioid, the federal opioid response money to fund various projects, and many have peer support specialists. So our substance use navigators in California are a little like that, but we don't name that they have to be peers. They have to care greatly about people who use drugs. So we were able to get our navigators into almost every emergency department in California. And they were in this pretty short period of time, able to see almost 270,000 patients. So they were able to identify more than 200,000 with opioid use disorder, because our navigators many of them are seeing people with alcohol use disorder, are seeing people with behavioral health challenges, but we are able to identify a lot of people with opioid use disorder in our emergency departments. And by identifying these patients, we were able to offer medications for addiction treatment. So we were able to, you can see almost 90,000 people were prescribed or administered evidence-based medication for addiction treatment. And that is really buprenorphine in the settings we are working in. We will offer methadone in many of our emergency departments. It depends on what the infrastructure is in these communities. And if you just look at, if you want to get naloxone, if you want to flood the streets with naloxone, give it to your emergency departments and make it easy. Josh is going to address that, but we're looking at almost 200,000 toolkits that were ordered by hospitals. And I know in my hospital, our naloxone is distributed like hotcakes. Like everybody gets some naloxone, and we made it really easy for them to access. So again, if you want to make a change quickly and get evidence-based medication out there, emergency departments are really the place for this. Next slide. We did set out, I have to say, to make a difference early on. Our goal is that this is standard of care. This is standard of care in every emergency department in California. And we have now 276 hospitals with California Bridge programs. There's probably more than that who aren't receiving funding and may be still giving buprenorphine. But the reason I show this slide is this is how much is happening every month. So every month, 8,500 patients are seen for a substance use disorder. This is the data that we get at Bridge. So there could be more, right? 3,200 patients are discharged with a follow-up appointment. They are given a warm handoff, a follow-up appointment, so that they have a seamless transition to care. And again, every month, 2,300 patients are administered or prescribed these medications. All right, next slide. And I just want to give you some context for this of what is being funded in California. We have, and I hope you can see all of this, but we have multiple different projects. So this is something from the UCLA ISAP site. So this is data that's not ours, but they compared what we're doing at Bridge in terms of getting medications out there. These are new patients. So what we have to do in order to save lives, right? We need to engage new patients, not people who are already in care. So look at how many new patients, that big blue line right there, how many new patients are engaged in care when we set up systems that originate in the emergency department. You can see it's compared to hub and spoke. We have a hub and spoke system in California. We do MAT in criminal justice settings. And, as we go through, we have youth opioid response. And actually Bridge has done a lot with youth opioid response. We've innovated some of our pediatric emergency departments to be points of access, touch point for some of our youth and adolescents who are struggling with their substance use disorder. And it's not just in California. So in this next slide, you'll see that we are working across the country. So And I'm so grateful to be talking to you in Kentucky. I actually just did a presentation for University of Kentucky. And so I know that there's a lot of interest in starting emergency department programs there, but there's interest across the country. So any narrative that emergency departments aren't interested in this work, it just hasn't been our experience. People just need the tools. People just need the education so that they can feel comfortable giving this medication. I worked a shift yesterday in my emergency department. We do a lot of things that don't carry as much evidence as what we're doing here. And this is just one of the tools in the toolkit, across the country, we can have an enormous population level impact. So we're working hard to get this information across the country. And again, so grateful for your attention today. So this next slide, I'm going to just sort of address the elephant in the room. Why the emergency department? It's expensive. It's, there's all of these things that, many people will tell us why the emergency department. But what we do know is because of EMTALA, the Emergency Medical Treatment and Labor Act, we are the one place that's the safety net. That's the demarcated safety net in the American healthcare system. So emergency departments are visible, right? On freeways, you'll see an H, or there might be a sign for emergency department. They're easily accessible. Most times there is a bus that drops off at the emergency department. So public transport is typically available. It's 24/7, so all hours access. If somebody is experiencing acute behavioral health issues associated with their substance use disorder, we can do both. We can stabilize folks. We can offer same-day treatment, so on-demand treatment. And if we are prepared for what we are seeing already, we can navigate folks to ongoing care. And then again, we're also a critical link to shelters, community treatment programs. So just doing a little bit of homework, we're able to see what's available in our communities to make sure that our patients have access to those community resources. Next slide. And again, why the emergency department? Only 10% of Americans with a substance use disorder will receive any type of substance use disorder treatment, any type, right? 1 in 10. And of those, only a small fraction receive FDA approved medication. Could you imagine this for any other medical problem? Hypertension, diabetes, any of the things that we consider bread and butter treatment. If we only had 10% who receive any type of treatment, and if most of those are receiving counseling and not FDA approved medications, it's unacceptable. And we have to change to make a difference in overdose deaths. Next slide here. I can tell you, a lot of us have been doing work to decrease opioid prescribing. It was my very first project in 2016. It was like a Kaizen project I was doing to see how we could decrease opioid prescribing. And yet that is not enough, because we have been decreasing opioid prescribing across the board. So from 2010 to 2020, you can see opioid prescribing decreasing. There was a big point between like 2012, 2014, where almost every American had a prescription for an opioid. So there was this oversaturation of the market with opioids, and we have decreased opioid prescribing since then. But what's happening? The significant increase in overdose deaths. We cannot rest with just decreasing opioid prescribing. Next slide. And I just have to say, history is being written right now. So we have to make some choices, because we're in the worst case scenario, maximum overdose deaths. We're hoping that this is the maximum. We're hoping that we make a difference and we're able to decrease overdose deaths. But there's just been this massive sustained exposure to the US population to opioids. And then all of a sudden we realized we had a problem. So there's been this abrupt regulation, restrictions, and not a push for treatment. And that's the important part here. That's why we're all here today. And what's happened in this vacuum between treatment and this abrupt discontinuation of opioids? Organized crime filled this vacuum. Fentanyl, methamphetamine. We see this every day in our emergency departments. And so it's important that we take a different view. I can tell you that I have practiced for 24, 25 years now, and 17 years of this, I have been a part of what's been going on in medicine. So for 17 years, I was not offering FDA approved medications for opioid use disorder. I wasn't offering it for alcohol use disorder either, but I had to make some practice change because that wasn't working. Referring people to non-evidence-based treatment, that was not working. So again, we're here to talk a little bit more about what we can do. So This next slide, I can tell you when I received some education about buprenorphine, I thought, why haven't I've been giving this medication before? I was treating withdrawal with just comfort meds, and I was referring people to abstinence-based treatment. And I had no idea what buprenorphine was. It felt like this very specialized thing. But once I integrated this into my practice, I was just talking earlier, it just becomes something that is regular medicine. So we'll talk a little bit about the major features here. And really what I want you to get out of this slide, I have a couple of these to show you, but there's, buprenorphine is a partial opioid agonist. And so it's very different from the full agonists of, morphine, methadone, heroin, fentanyl, hydrocodone. So you got those full agonists. You've got this partial agonist that has some really desirable qualities that make it safe, make it very, very safe for us to give to our patients. And then you've got the antagonists, you probably know about naloxone, of course, and naltrexone. So in this next slide, I'll get a little bit more into this, why it's so safe. So it's because it's this partial agonist, we've also seen a ceiling effect. And this is what we're showing you here with that blue line, this ceiling effect on respiratory depression. And that's extremely important to me in the emergency department because people die because they stop breathing. So again, having a ceiling effect on respiratory depression has been very important. It also has a ceiling effect on sedation. And then at the same time, at the right doses, it blocks other opioids. Now, in the same tune, it can displace other opioids. So Alicia is going to tell us a little bit later today how we, how we can give buprenorphine. But I want to make sure you know that, yes, it blocks other opioids, but there is a timing thing to give it so that we are not displacing other opioids. But the other thing that we like about it, it has a long half-life, so 24 to 36 hours. So if I'm able to get buprenorphine on board, and I am passionate about getting buprenorphine on board for our patients who are at risk, then they have a little safety period. And sometimes that safety period of 24 to 36 hours is what they need just to kind of get a reset and figure out what they want to do. Doesn't mean they have to sign up for a program or, quit their job, leave their family to go enter treatment. It just means that they may want to take a different path, and we can offer that to them. So next slide, a little more information just so you can see that we know about the ceiling effect on respiratory depression. And I have tested this in my emergency department, and it holds true. So yes, you get a little respiratory depression. You can see it goes, you can go from 20 respirations per minute to 10, but then there's this ceiling effect there. People will keep breathing. Whereas when we look at, fentanyl, this compares to fentanyl, people stop breathing. So this dates way back. This article came out, I think, in 2006. All right, next slide. And then this is what was also really important to me, is that detoxification just doesn't last. I didn't know this. I thought that people needed to go to inpatient recovery. Some people do benefit from that, but that has to be paired with medications, because when we do what we have been doing for years and years and years, which is detox, right? Get people off of the opioids, not give them the medications that support them, that help them with craving, that block the other opioids, that have a ceiling effect on respiratory depression. Most often they return to use. So in fact, the detoxification and to abstinence treatment works for the less than 1 in 10 people. There is no other medical problem that I would be okay with it working for less than 1 in 10 people. So again, I had to make the change. I made the change back in 2016, 2017 by simply asking a question of how, what we were doing to support people with opioid use disorder when we saw them, when we developed some tools to screen. What were we doing when we actually found opioid use disorder? And at the time we were not doing enough. And so we made a simple practice change by just giving the right medication at the right time. All right, so I'm going to get into a case here, and then I'm going to turn it over to my partner, Jean Hearn. But let's just meet William. All right, we're going to do a case study, and this is somebody that we'll talk about through our presentation here. But this is a patient like many of the patients that we treat, but it's 2 a.m., 911 was called, okay, for a possible overdose. So we find a 22-year-old found unconscious. He's been recently released from jail, and he regains consciousness after naloxone was administered. So already a win, because we have naloxone out there, right? We want to saturate our streets with naloxone so it's available. So naloxone was administered. The patient is now feeling significant withdrawal. He's feeling awful. he's requesting self-discharge, right? So 911 has called, they show up, and William wants to leave because he is craving and he is feeling awful. I want right now, just think about what resources 911 paramedics in your county, what can they offer this person right now? So what do you think would happen with William right now in your county? All right, next slide. So I'm going to have Jean take this away from here. So Jean, I'd love to hear from you about what happens with this patient, you think in a lot of places, and then, maybe we can talk about what could happen. So, walk us through like a patient experience starting with EMS. Okay. So,
Absolutely.
What's the approach that we should take with this person?
Yeah, it's a great question. So as a EMS medical director, typically in EMS systems, there's a traditional sort of you call, we haul mentality. EMS is typically a very binary type of reaction. And I think that's one of the things that made us sort of think about, like, maybe there's something else we can offer here. So my name is Gene. I'm an emergency physician. I'm also an EMS medical director for both public and private agencies. Next slide, please. So there's what's classic is there's this gap in care, right? The traditional EMS model would be assess, treat, maybe treat symptomatically. A lot of paramedics and state medical protocols allow Zofran, and that's usually about it. And then transport. And of course, these patients aren't feeling very well. They're in withdrawal, and it makes perfect sense for them to not want to go to the hospital because there's a lot of barriers there. They may not have had good treatment there before, or a lot of judgment. And so maybe they want to sign out against advice. So let's talk about the possibilities that we considered. So a few years ago, my bridge colleagues and I started brainstorming about how EMS could get involved, because typically there might be a lot of patients that never make it to the emergency department. They might sign out against advice and be released on scene. But we can talk about a number of different models. The new standard would be assessing patients, screening for substance use disorder, approaching them from a motivational interviewing standpoint, talk about substance use disorder treatment, talk about buprenorphine, consider buprenorphine administration, provide them with a leave behind naloxone kit, transport them to a specialty center like a trauma center that's actually equipped with the personnel, the knowledge, and the training to treat overdoses and patients with substance use disorder. Additionally, the possibility of like a warm data handoff to public health and then continued follow-up. So there's a lot of things that are on the table that EMS can be an active participant in for these patients. Next slide. So again, when we think of EMS interventions, it typically is right at the overdose occurrence, right? So that's what I call that binary response. But there are things that can happen before and after that. So before, you can think about screening, safe drug drops, education, again, the naloxone kit distribution, perhaps drug testing or checking. Then there's the overdose. And then after the overdose, there are all these other things I sort of mentioned before, overdose receiving centers, a warm handoff, perhaps home visits after ED administration for follow-up, an at-home MAT. That happens in a couple different places around the country. And then paramedic-initiated buprenorphine. So the things that are in orange are the things that we adopted in Contra Costa as our pilot project. Next slide. So we consider it sort of 4 pillars of our intervention. And this was a sort of a 3-legged stool between the public health department, the medical director for the county, and the medical director for the 911 transport agency, which was myself. And so what we did first is we designated an overdose receiving center. So the county hospital in the early days was the only bridge site in the county. Now we have, I believe, 6 or 7 in Contra Costa. And again, it's a place where you have dedicated personnel who have the training. The ED providers are comfortable using buprenorphine, comfortable giving prescriptions and that sort of thing. And so we recommend that our paramedics take our patients there. And I'll get to that data in just a second. Again, a naloxone education and distribution program. So naloxone distribution sort of system that's actually funded through a state grant. So the naloxone comes to the EMS agency and they just stock it on the rigs and hand it out to bystanders, friends, families, or patients. And then paramedic administered buprenorphine, which is actually only happens in a few places around the country right now. Although I'm told that Kentucky just launched, which is amazing and super awesome. And then a system integration with data. So let's go to the next slide and we'll talk a little bit more about these.
Yeah, and Jean, yeah, I'd love to hear from you. Like, what do you think the key steps are? Because this all looks great. Like, I think a lot of us would love to have this going on in our county, right? Because you're meeting a lot of the different important things that we know work. But I'd love to hear, how you're building this system.
Yeah, great question. I mean, part of it is buy-in from what's really cool is having a conversation with both EMS and public health. Oftentimes that those organizations or those departments tend to be a little siloed. COVID sort of brought them a little more together, but typically public health hasn't engaged EMS in the same way, at least in California, in my experience. And so part of that is sort of building the groundwork of showing that we have the data, that we have great follow-ups, our patients are engaged, and yet having that ability for both the public health side and the EMS side to come together to figure out a way to have data transfer and perhaps the designation for these hospitals that are a little bit more specialty focused. So that's absolutely key. And then champions, and that's I think the thing that sort of keeps coming through through all of these projects that we've launched throughout California is, you have to have champions within the agencies to have it be sustained.
Yeah, I was going to say, I think each one of us here started out as a champion of something, right? So we're hoping there's 600 champions at least on this presentation. Become a champion. Yes.
Absolutely. Right. No, that's huge. It's absolutely, it's incredible. So paramedic administered buprenorphine is sort of the thing that people talk about a lot with this program, because obviously it is a longer term solution. We were the second place in the country to have 911 administered buprenorphine. Camden, New Jersey, huge shout out. They started this. They unfortunately can only give buprenorphine to patients post naloxone withdrawal. Our protocol expanded that to allow buprenorphine to be given to patients who are in any kind of withdrawal. So abstinence withdrawal, naloxone withdrawal, and then the very rare precipitated withdrawal. We haven't seen many cases of that, but we certainly allow that within the protocol. The protocol is pretty straightforward. It doesn't take any additional staff. We have our training down to less than an hour for our portion, maybe a little bit more for local ops. But it's actually a pretty remarkable system. And then there's an expert physician consult that applies where they call the base hospital or a consult line just to run the case, buy them, and then get approval. And so there's been a couple papers that we've published so far, both a paper out of Camden and our papers out of Contra Costa that have been pretty remarkable in terms of showing that it's a system that has been implemented. It's 911 street medics. They don't come the next day. They don't come 6 hours later. They have buprenorphine on the rigs, and they can give buprenorphine where the patients are. Next slide, please. So this is our protocol. It's a little hard to read, but if you pull out your phone and QR code it, it'll take you to our Bridge website where we have a lot of our EMS protocols as well as some of our trainings. But basically what we go through is we go through exclusion criteria and inclusion criteria, and then the patients do a COWS score. And the COWS score is the clinical opioid withdrawal scale. And if their COWS is greater or equal to 7, then they are eligible for the treatment. Then they reach out to a protocol physician who runs through the case, make sure that everybody's in agreement. And then the paramedics will give 16 milligrams sublingual of buprenorphine in the field, and then they can follow up with another 10 minutes later. Next slide, please. And then this is, I think, perhaps the secret sauce to the EMS integration and our EMS successes thus far. It turns out that the key to a good systemic and data integration is to not have many more steps for our paramedics in the field to do in order to get these patients in the system. Because these patients might sign out against advice. They may, be left on scene and not even make it to the emergency department. So our paramedics fill out their charts, and we use a data dredging software called First Watch, which is nationally available. And what it does is it looks for overdoses and overdose triggers. And then it sends those triggers to our public health substance use navigator, who then follows up with those patients, checks in with them, see if they need a prescription, if they need a follow-up appointment. So even patients who don't make it to the emergency department are linked into the system. And that's truly the key, I think. Buprenorphine is very sexy, and it's an important part of this process, but I honestly think that the secret sauce might be in the data connection with public health and the substance use navigators. Next slide. And again, so this implements the warm handoff component where the public health navigator, EMS, and the county hospital are both under the Department of Healthcare Services within the county. So the EMS patients with the substance use disorder are then flagged. The navigators provide follow-up. They provide that wraparound treatment, connection, resources, phone in a prescription or get a prescription to them if needed. Next slide, please. And this, I think, is a super interesting slide. And this is some of our early data talking about the retention of patients at 30 days if you take them to a overdose receiving center or a bridge site versus any other random emergency department. And this was actually really interesting for us because if you look at the bright green column, if you take a patient to the bridge hospital, they would have a 30% 30-day follow-up rate. So 30% of our patients who get buprenorphine have been retained in treatment at 30 days versus 20% if they go to another hospital that may not be a bridge hospital, that may not have substance use navigators, where the ED providers may not be comfortable using it. And I think this is sort of illustrative of the concept that we'll talk a little bit later in this webinar about having emergency departments that are fully utilized to deal with patients who have substance use disorder, who are comfortable, who are able to engage patients and do motivational interviewing and partner with these patients and get them hooked into treatment. And that's truly, truly the key to, I think, how this program has been successful. Next slide, please. And then this is sort of our final slide in terms of data. And this is the exciting part, is that over the course of our project in Contra Costa, we've had a decent number of people who have been retained in care. And while buprenorphine itself, as Ariana mentioned, is protective from overdose for the next 24 to 36 hours, what we really care about is that long-term engagement, because patients who are engaged in treatment in a long-term treatment clinic setting have an incredibly reduced mortality rate. I think it's like 70%. There's almost nothing in medicine, as Ariana mentioned, that has that level of impact for mortality on our patients. So that's stunning. And so we were really surprised about this. And we're super happy that this has been adopted by so many places in California. I think now we're up to about 4 million Californians who have buprenorphine on the rigs in their respective counties. So, but yeah, basically 30% of patients are continuing in care at 30 days.
That's really incredible. So William, if we bring it back to William, so if William is offered evidence-based treatment, so William's offered something that, number one, may make him more comfortable, because I can tell you a lot of folks who have been reversed come into my emergency department, if they even come. Like if you pointed out, Jean, they could sign out AMA and never, sign out against medical advice and never make it to our emergency department because they're feeling awful. And to be honest, they may want to just return to use, but giving an alternative, something that will on the spot make them feel better, can make such a huge difference. And obviously engage people in long-term care, which is incredible. I also say, sometimes if people are just exposed to something that makes them feel better, even that, that percentage of people who may not have stayed in care, they may have had an experience where they know that could work for them in the future. So it's not all for naught, right? We have people who stay in care, and then any exposure, positive exposure, I think could be really important. And so let's say William accepts medication. William wants to go to the emergency department now and is sort of believing in the system. So I'm going to turn this over to Dr. Alicia Gonzalez, who has been our director of training at Bridge and who is awesome. I love listening to her and hearing how she can take us through what we do when we get to the emergency department. And I know, Alicia, you do this every day. You do this all the time. of
Exactly.
how we're treating people in our emergency departments in California and what we're trying to do in Kentucky and across the country. So take it from here. What happens with William when it comes to the emergency department?
Awesome. Thank you. So I want to first point out, I looked at a couple of the questions that were being posted in the Q&A, and I think a lot of them are going to get answered in this segment. So if I marked them as answered, it's because I'm about to answer your question. We aren't ignoring you. So I am Alicia Gonzalez. I'm an emergency physician, and that's really the lens that I'm going to be talking to you through today. And so the first question we want to answer on the next slide is, what does low barrier access to buprenorphine really look like? Like what does that mean? How did we do that? And I think the most important part of making something low barrier is bringing it to where the patient already is. So on the next slide, you'll see that there is a known statistic nationwide that 28%, so about a quarter, almost a third of adults that are in the emergency department screen positive for a substance use disorder. Now, this is the people who come forward and say yes. Like when the nurse says, oh, by the way, do you use any drugs, alcohol, or whatever? They say, yes, I do. So we can also assume that this number is underestimated, that it probably is even higher, which is a shocking number, right? That about a third of people that come to the ED screen positive for a substance use disorder, which means this is where the patients are. People who are using drugs are already coming to the ER. And so we wanted to bring the treatment to them. The next slide will show you the basis of the California Bridge model, which is making sure that access to treatment is a low barrier, which means right there in the ED when you need it, or like Dr. Hearn just described, even from an EMS rig, right when the person needs it, when the paramedics respond. The next piece, though, as he mentioned, is going to be the same for us, is a connection to ongoing care in the community. The emergency department's role is resuscitation and stabilization. And it's the same thing for substance use. Somebody who is really suffering from opioid withdrawal, we want to be able to stabilize that patient, make them feel better. But I'm not going to be their long-term addiction care solution. That's not what we want it to be. So we do have to have a smooth pathway to get those patients into care. The system is really difficult to navigate if you don't have somebody, we use navigators, but if you don't have somebody really intentionally connecting those patients to ongoing care. And the final piece is building a culture of harm reduction. And this actually has two pieces. The first one, this is one of the questions that was placed in the chat, has to do with getting rid of stigma. How do you get a house of medicine that for many, many years has called people addicts and has talked about getting them out of here and talked about, all their drugs as being these moral failings? How do you take this culture within healthcare and shift it towards addiction as a chronic medical disease that has evidence-based treatment, and that these people are worthy of our care, and they're worthy, they deserve the treatment that comes along with their chronic disease? So that's one big piece of it, is the stigma shift. The other is making sure that all of our clinical providers are much more comfortable talking about decreasing morbidity and mortality from using drugs, right? We know that people with diabetes don't always take their medicines, and they're still going to eat donuts sometimes, right? And so we have to talk to patients about minimizing the morbidity and mortality of their diabetes. The same thing is true with drug use. If somebody who uses drugs is in treatment, they still might relapse. They might use different drugs that are out there. And so how do we make sure they're not getting HIV, endocarditis, overdose, and death, right? How do we keep people alive and help them live well? Because the longer someone lives, the more likely they are to have that moment where they're ready to enter treatment. And if they're dead, they can't have that opportunity. So we want to keep people alive and help them live as healthy as they can until they're ready. What does that look like as a treatment from the ED? Well, here you go. I'm going to have them go to the next slide, and I'm going to put this in the chat really quickly, which is a link to our California Bridge program, quick start guide for buprenorphine. This is how you start a patient on bup in the ED. I'm not going to do a massive deep dive, which is why I put the QR code here, but also the link in the chat. Please take a look at it when you have some more time, but I will walk through the basics. So what happens is, on the next slide, step one, the patient has to be in active opioid withdrawal. If you're not comfortable knowing what that looks like, Dr. Hearn mentioned earlier, there is the clinical opioid withdrawal scale. That is not necessary. Please don't build protocols around mandating that providers and nurses document a COWS. It is more just a utility, like a tool there that's able to be used for somebody who's less comfortable. I don't need that tool. I've been doing this long enough. I can see across the lobby that that person is in opioid withdrawal, so it's not necessary. but we want patients to be in at least moderate to severe withdrawal. That is because buprenorphine has really high affinity for the mu receptor, the opioid receptor, which means if they're still with a lot of full agonists in their system, fentanyl, heroin, methadone, if we give the buprenorphine too soon, it will pull them down from that high and precipitate a withdrawal, which makes them feel a lot sicker really fast. And we don't want to do that. So they need to be in at least moderate to severe withdrawal. And we define that as saying that they have a score of 8 or higher on COWS, but that we can see objective findings. Are they tachycardic? Are they sweaty? Are they vomiting and having diarrhea? Are they pacing? Are they yawning? Do they have goosebumps? All those things that we know opioid withdrawal looks like. So if they're in withdrawal, we give them between 8 and 16 milligrams of buprenorphine. You heard Dr. Hearn mention that they use 16 in EMS. We're actually updating this protocol to start with 16 as well. Some patients, 8 milligrams will be enough, like if they have a very low usage pattern, but a lot of patients, especially those who use fentanyl, have really high tolerance. And so 16 is a very safe dose. And I have routinely started patients on doses even higher. So we don't want to go low doses. Please don't be giving like 2 and 4 milligram doses. Those are too small, at least 8, ideally 16. And for patients who tell you that they have a heavy use pattern, don't be afraid to go higher, 24, 32. It's very safe. There's no respiratory depression coming. So you give them the medicine, and then next slide, you wait a minute, 30 minutes, maybe 45 minutes, and then you recheck your patient. And if they're getting better, awesome. Give them a little bit more buprenorphine. Give them enough buprenorphine that they feel normal, not high, but just normal, because their body now physically depends on opioids to feel normal. This is akin to somebody who has diabetes who needs insulin. There's not like addicted to insulin. Insulin is what makes their body function normally. Buprenorphine allows a person with opioid dependence to function normally. And so we're trying to give them enough to feel normal and to not have any more withdrawal symptoms. If the person did not get better at all, I would still give more buprenorphine if the story is good for withdrawal, but take a step back and think about, are you missing something? Is it alcohol withdrawal? Do they have COVID? Is it sepsis? Like, what did you miss? Because if it's plain, simple opioid withdrawal, it should get better with enough buprenorphine. The number one reason people don't get better is that we didn't give enough medication. So don't be afraid to give more of that medicine. And then finally, once the patient's ready to go home, on the next slide, you can see we send them home with buprenorphine. There used to be this crazy little thing called the X waiver, more barriers for these patients, but it's gone now. We don't have that anymore. So any clinician with a DEA license that includes controlled substances, meaning if you're allowed to write a prescription for hydrocodone or oxycodone, you too can write a prescription for buprenorphine with no special licensing and no special anything. So feel free to do this today. And we want to give patients somewhere around between 16 and 32 milligrams a day. And that can be divided in between 1 to 3 times daily dosing, whatever the patient prefers. Some patients like to be on, for example, 8 milligrams twice a day or 3 times a day, as opposed to 16 once a day. It's a little bit of a conversation with your patient about what they think would work better for them. But all of that is totally acceptable. We want to give patients a prescription long enough to get them to follow-up care. So if you know it's going to take 2 weeks or 3 weeks for them to get into their follow-up provider, give them a prescription long enough to get them to the follow-up provider. Because what happens if they run out? They go back into withdrawal. And now what happens? They're probably going to need to cope somehow. And that's going to drive people to seek illicit drugs to meet their withdrawal symptoms. And that's not fair. We want to make sure that they're able to stay in treatment as long as that they can. This is not in my presentation, but I did see a note in the chat asking about taking people off of bupe and this idea that we're replacing one drug with another. I would really challenge anybody who thinks that way to reframe this as a chronic disease that requires medication. I mentioned the diabetes example. You know, we don't say we replace one drug with another when we put somebody on insulin, and we don't talk about when they're going to be able to come off of insulin because their body chemistry has changed. They need insulin to function normally. That is true of people who need buprenorphine. Their body is now dependent on having some opioid in it to function normally. And studies have shown that when you take people off buprenorphine, when you taper them off and you take them off of it, that they die. A lot of them go out and overdose and die. And it's really dangerous to do that. So we don't want to do that. We want to reshape how we think about bupe. It's a medication that we are prescribing to help people live well. And if you need more information about that, please, email any of us and we're happy to have a longer conversation. So next slide, another question that was posed in the chat by multiple people. What about stigma? Did we have to deal with stigma? No, of course not. Everyone thought this was a great idea. Just kidding.
Yeah, Alicia,
So
I was
much
going to
stigma.
add to this is like, I think a lot of us, like, because you just went through the medication part, and like I remember going through medication and I'm like, okay, this makes sense, it's not too bad. But then you hit the stigma thing where you do get folks who will say, you know, aren't you just replacing one opioid for another? And it comes from patients too, because
Yeah.
if we haven't provided that kind of education to our community, many people will say this, right? So yeah, I'd love to hear how you kind of, you know, now we got the medication part. How do you work with this so that people get that kind of care so we can normalize this?
Totally. So I think the next slide shows you a bunch of quotes that patients actually said. These were published in a study, just to give you an example of how ugly the impression can be for patients when they're, you know, working with us. We say pretty mean things to people, honestly. And I'll be very, very candid that I have been that person. Like when I was back in training, we used to say mean things about kicking people out and calling them junkies and addicts and tweakers. Like I've been there. And so I'm really like trying to own this for you, that if that's you or you're struggling with, you know, your own relationship with patients who use drugs, I think that's normal. I think this is like a hard thing to talk about. But when you look at these quotes on the slide and you realize like these are all humans, it's really important for us to take this head on. And so here's my like recommendation that we always talk about at Bridge on the next slide is building a culture of radical acceptance. And these are the words that I use when I'm working with our staff, because we do have, you know, nurses and clinicians at every hospital we worked with so far, and pharmacists, et cetera, who will vocalize their hesitation or, oh, if we start this, aren't all the drug addicts going to come to our hospital now? And you're like, oh my gosh, 30% of people in this lobby already use drugs. They're already here. We're not like trying to attract people. We're trying to do good by the people who are already here. But it's this idea that we have to first demonstrate what that means. So in your own behavior, can you be very intentional with your language, saying substance use disorder, or, you know, a person who uses opioids or who has opioid use disorder instead of an addict or a junkie or an alcoholic, right? Like using our language to describe it as a medical disease. And then walking the walk. When you talk to your patients, you have to normalize it a little bit. Like you're not stigmatizing this person. You say, you know, a lot of my patients use drugs like fentanyl. Do you ever use drugs like fentanyl? Do you think you might be in withdrawal? Making it a little bit more comfortable for them to be able to say yes and talk to you about it. You have to acknowledge that there is this history there. I know it can be hard for you to talk to like a doctor or a nurse about this kind of stuff. I'm sure you've had bad experiences before. However, and then here's the third piece of advice, align yourself. You want the same thing. So you say, however, my goal is to make you feel better. Like I want what you want. And so can we talk about what that looks like today? And then the next piece, ask questions. And this is true of people. So on the next slide, true of both your staff, but also your patients. Before you assume things, ask your patients, do you want to be off drugs? Why do you take drugs? You know, how did we get here? How do you use your drugs? Have you ever heard about buprenorphine? But then with your staff, why is it that you feel that way? Like, why are you so angry? Or what is it that's making you feel so resistant, you know, to these medications? And I feel like by asking questions first, we always get way further than by assuming that like a staff member is bad or like jumping into a lecture. So normalize for the patient that this is a thing that you see a lot. They're not, you know, unique in their struggle. Acknowledge that we have a bad history, align yourself to be on the same team as them, and ask questions for more information. If you're not comfortable, next slide, if you're not comfortable with how to ask those questions, practice. That's my best piece of advice. Here's a couple of recommendations for you on the slide that you can practice. It's the same way that we practice. How do you tell someone their family member died, or that like their kids using drugs, or that like someone got abused? We have a lot of tough conversations we have in acute care, and those things take practice. We practice it. So I would recommend practicing saying these things in the mirror until you feel better about it. You know, it might take time for the medicines to work. I know you feel sick right now. I wish it was a magic wand. It's not, but I'm here for you and I'm going to help you feel better. I promise. You know, I know that it's been a scary place for you to be in the hospital today in the past, but my goal is to change that today. I'm here for you. We're on the same team. So practicing saying these things. And then last thing, you have to, on the next slide, work to break this down in your system. Get rid of barriers. Stop doing your toxicology screens that aren't helpful. You know, don't have 50 million handouts people have to fill out or a bunch of insurance pre-authorization. Like just start the medicine. Just start it when they say that's what they're here for. Start the medicine, make them feel better. Get somebody that can help connect them to care so that it's a smoother process. And really work to get rid of those barriers. That helps with the stigma piece too. And the last thing I will just throw out is that if you are not sure how to get started, if you want to go ahead 2 slides, the California Bridge program has an amazing blueprint. And so here is a link to that blueprint. You can investigate the whole thing, but a couple of the key action items on the next slide. You have to put a team together. We talked about building champions. Please get your champions across the hospital. You have to make sure that you have ways to do prevention, like don't use opioids when you don't need it. So do all your staff feel comfortable knowing what alternative medications are to do a good job treating pain without having to use opioids as first line? But do you have buprenorphine on formulary, it present in your emergency department, in the machine, not from central pharmacy, like ready to give that patient as fast as you can give, acetaminophen? And then making sure that all your mechanics are there. Can somebody order the medicine? Is it easy to prescribe it? Do you have all that set up? Is there a way to link care, a warm handoff to ongoing care? And then education for everyone. And this is the most important piece, and it has to be a little bit specific, right? Questions pharmacists have, not the same as questions nurses have, not the same as questions doctors have. So you need to give everyone in your team some time to learn this from their perspective. And truly, by doing a lot of education and repeating your messaging, that will help people come around on their stigma as well. When they see that this works and they watch the beautiful effects that it has on people's lives, it's really hard to maintain your stigma when you're seeing so much success in saving patients. All right. I know that I talked a lot about opioids, and Ariana, I know when I first met you, one of the things we always talk about is that I wish there was a buprenorphine for methamphetamines. I wish that it was that easy.
I think we felt a little helpless at first, but I think it's important to address because, I mean, I always say there's something for everybody. We can meet people where they're at. We can help them. So yeah, maybe tell me about what we can do. If let's say William's struggling with methamphetamine. William says, actually, I just used a fentanyl once. What if most of William's problem is methamphetamine that he's struggling with? What would you do?
So if you want to jump ahead for me 2 slides. So when we talk about stimulant use disorder, or STUD, this is a way more challenging one. I think it's just so much more challenging, and I wish there was a magic wand answer, but there isn't. But there are medication options. So on the next slide, we'll talk about 2 that are, well, the first thing, which is to treat the person with both medications to help calm them. The psychosis they're feeling, you can treat that with like olanzapine. So if they're doing they're very hallucinated or delusional. And then sleep. Patients who have been using methamphetamines need sleep so much. So facilitate sleep, whatever that looks like. And methamphetamine intoxication and methamphetamine washout or withdrawal really need the same thing in the acute phase. Reduce the stimulation, get a calm environment, and give them medications, benzodiazepines, olanzapine, and diphenhydramine if you're trying to facilitate sleep, something to help people rest. So critical. But going forward from that, on the next slide, 2 of our best options are going to be mirtazapine, which most of us know this as like a behavioral health drug, but mirtazapine actually can decrease overall the amount of methamphetamine that people use. It's not incredible. I'll show you a graph in a second on the next slide, but it is something. It is something. And it's a pretty safe medication. So you can try mirtazapine 30 milligrams at night. And then second line, you can use, I'm going to say Wellbutrin, not because I love the brand, but because bupropion and buprenorphine sound very similar. So I'm going to say Wellbutrin just to be clear. Wellbutrin is another medication that really does help give people a little bit more energy and takes away the dysphoria that comes with coming off methamphetamines. There's a lot of depression that people feel when they're used to being stimulated on, a stimulant, and now they're off of it. And so the Wellbutrin piece can help with that a lot. And then naltrexone actually can decrease the risk of, unintentional opioid overdose, but also has been helping people to abstain from methamphetamine a little bit. Not overwhelming evidence, but pretty safe medicines and worth trying. There are a lot of other meds that have been tried in a lot of other studies out there. None of them are quite as convincing, but the point is people are looking for an answer. They really are. And the next slide, this is the last one from me, but we'll just show you, again, these benefits of mirtazapine, not drastic, not incredible, but it is something. It is less. You can see that the orange line, patients on mirtazapine do use less methamphetamine than those who were using a placebo. So it's something. I recommend trying it. You can start both the Wellbutrin or the mirtazapine safely in the emergency department. It's not super dangerous to do. And just know that a lot of us are out there working on finding a better answer.
Oh, well, thank you so much, Alicia. I appreciate that. I'm gonna now turn it over, next slide, to Josh Luftig, because what if William, I think part of, Alicia, what you were talking about is, I mean, I think we have to integrate harm reduction to everything we do. Harm reduction for me, I learned from the Harm Reduction Coalition. I've learned from partners who helped bring me on board. It's a way of life. It's a way of being as a provider. So I'm able to, I've learned from Josh so much about the impact you can have with harm reduction. And some of it is like, if William says, I don't want any of this, like I wasn't expecting to overdose today. I was having a good time. This is William may say, this isn't my normal pattern. I don't know, I don't want anything. Or he does want something, but maybe he doesn't want to follow up. What can we do, Josh? Like, how can we reduce the harms to William so that William can lead a safer life or meet his own goals?
Ariana, thank you for setting it up that way, because that is really common. We often encounter patients who the nurse may come up to me, or the social worker, or someone involved in the patient's care may come up and say, yeah, they're just not ready. They're not interested in what we're offering. They're not interested in buprenorphine. So I want to do a little bit of a frame shift for all of us in healthcare in how we think about assessing readiness, and get away from this kind of readiness discussion. So the reflex for, once you've identified someone at risk who you believe has opioid use disorder, which we have in William, who's presenting after an overdose, anyone coming in after an overdose, or your assessment is they have an opioid use disorder, they get buprenorphine. Like, buprenorphine is the treatment. It's like if you've identified raging cellulitis, antibiotics are the treatment. Out of control diabetes, insulin, metformin, these are the treatments. So we're not asking if they're ready to treat their cellulitis. We're saying, this is what this is the treatment for this condition. And the way you can have this conversation, often what people are afraid of is they're like, well, I'm not ready for a whole treatment program. I'm not, just in this moment, I don't know, this is a lot to take on. I'm not ready to take that step. And that's fine. So this is where we get into the conversation around stages of change. So if they're in what we would describe as a pre-contemplative stage of change, in this moment, that can change in 10 minutes, in an hour, the next time when they're withdrawal, the next morning, the next day, the next week. So we, in having that conversation with the patient, it's like, I get it right in this second, you're feeling that way, but this is standard of care. I'm going to make this prescription available to you. And you can, I mainly want you to try this next time you're in withdrawal, because it's going to make you feel much better. And this prescription that I'm going to give you is, in most states, is valid for 6 months. So you've got all this time, and this is your safety net. And I'm actually going to give you a brochure, which is you can find this on the California Bridge website, which is the Home Start or Self Start brochure, which it tells people, and it's a 1-pager that gives a really clear instructions on how you start buprenorphine at home. And they can also use what we describe as a pill in the pocket approach, just like finasteride for AFib. Like, when they feel they're in withdrawal, they can just take a dose and have that exposure to the medication. Or if maybe they've actually gone through withdrawal and they're worried about a situation that's coming up, like they're going to be exposed to people who are using, and they're actually trying to maintain abstinence, then they could take buprenorphine as a protective medication. And we also want to recognize that withdrawal is an emergency. So what happens when people are in withdrawal? Bad things happen. So patients are going out and they're finding, in desperation, they're finding a new dealer. They're using alone. They're using without naloxone. They're having situations that they would, if you're not in withdrawal and they have their wits about them and they're not having this urgency, they can be safer. And then withdrawal tends to lead to much increased risk of overdose and harms from use. Yeah, and the other thing around exposures to bup, we know that any exposure to buprenorphine, and we know this from the research and also just the experience of just talking to patients, a lot of them have tried bup in the street, and that any exposure to buprenorphine will increase the chance that they will actually engage in treatment later because they've had such a positive experience with that medication. Next slide, please. Oh, actually, sorry, we went through that slide. So next slide. Let's see, I'm out of order here. So The other thing is we want to allow, most states allow EDs to distribute naloxone via standing order. So we want to, this is Kentucky, falls in that category. So you have great legislation that is very similar to California, which allows a emergency department to one prescription. Basically, you have one. Often you'll have you can have a statewide standing order, or just someone in your emergency department can issue a standing order, and then that will be what covers every naloxone that goes out of your department for years. So you can just have that one standing order will allow naloxone to be distributed out of your ED. And it's relatively inexpensive. And there used to be the auto injectors that were thousands of dollars, I believe, and now we just have the nasal sprays, which are they're around $30 to $40 in that range for the pricing, which is very cost effective. And there's statewide, most states have some sort of public health intervention where they're being provided to your libraries, schools, police departments, prisons, jails, and the emergency department can engage with that supply of naloxone that's coming on a statewide level and use that same system to begin to distribute free naloxone from the emergency department, take home in-hand naloxone. And when you engage in distributing naloxone, this reduces stigma and bias. As a patient comes in and they see that your hospital is engaged with naloxone distribution, that sends an amazing message to your to the patient population, to the community. Like, they see that's part of the historic, as Alicia was talking about, the historic challenges that healthcare has had with the population at risk. That starts to fix that, because now they recognize if you're coming in, you're at risk, you have substance use disorder, and you see that they're passing out naloxone there, that sends a huge message without anyone opening their mouth. Just seeing signs around that, being offered naloxone, really sends a powerful message that this is a different care setting. You're gonna get compassionate and meaningful care. It's highly patient-centered. So that's this is really meeting people where they're at. We understand that we want to offer every tool we can, whether it's buprenorphine, whether it's naloxone, whether it's fentanyl test strips. We're thinking about different ways that we can, as a care provider and a care providing system, what's every tool we can give to keep people safe. And through offering all those elements, we really increase engagement with healthcare. So patients who have felt disconnected from healthcare, they felt it's been a hostile and unsupportive environment. Now they feel like they're seeing all this, this relationship is changing. They're finding a place that is actually useful and meeting their very real needs and improving their health. And so then later, if they're maybe less likely to start actually MAT treatment with buprenorphine, that helps open that door, because now you've got your foot in the door with the other elements of harm reduction, and then later the actual treatment part, which may be the last step, that becomes easier to get to. Next slide, please. And a little more about naloxone. It of course reverses overdose, so it is the antidote for an overdose. Sometimes it can take a couple of sprays. They're the most commonly available spray is a 4 milligram spray. Sometimes it takes a couple, especially if someone has had a lot of fentanyl. It can take additional dosing. It's very simple to administer. It doesn't even have a cap on it. The training is very rapid. You'll see these box flaps. The box actually has a flap that opens and has the simple steps 1, 2, 3. Patient's unresponsive. You think that they overdosed. You try to arouse them. They don't respond. You open up the spray. There's no cap on the spray. It just goes right up the nose and you push it. I can train someone in about 30 seconds using that, the box flap, and then the 1, 2, 3, and answer any questions. So that is very efficient. It used to be, historically there was only an injectable form that was available, and that required a little more training. And luckily we do have the sprays now, which are very easy to use. It's incredibly safe. If someone's not overdosing and you give them a nasal spray, there will be no effect at all. It's like water. And we want to make sure that we're thinking not just about the patient, but we're also thinking about their support network. So their family, their friends, and making sure that the people who can actually respond to that person overdosing are that they have naloxone and they know how to use it. So as you're setting up your system in your hospital, you want to consider the fact that not just patients should be receiving this. You want to be able to make sure that their entire support network is also able to have naloxone. Next slide. And fentanyl test strips. So these are very simple immunoassay tests, similar to pregnancy tests and COVID tests. So because of COVID, people are much more familiar with these types of tests. They're not a perfect solution. You do have to test, theoretically you would test every single substance. Every time you use a substance, you would do a test on that substance, but that's not really practical for most people. So you want to use a strategic approach. Like if they have a new supply that they're obtaining a substance from, then that would be a time to do a test potentially. And you want to make sure that they have a lot of tests. They're very inexpensive. They're around $1 to $2 each. And the one thing to be aware of as well is that stimulants can cause a false positive. So, and that's true with the older tests. That's why we have a picture of the two different types of tests. So on the bottom, you have the older ones, which are the rapid response test strips, which generally are blue. And then on the top, you have the dance safe fentanyl test strips, which are yellow, and those ones do not have the problem with stimulants. So that was kind of the Achilles heel of fentanyl test strips in the past, because often that would be part of the strategic testing, is that most people who are using opioids are familiar with the opioid. They're kind of riding that edge all the time of overdose. So they're often very sedated. They are more keen on what, if someone is using opioids regularly, they're pretty familiar with what an opioid overdose looks like. Whereas people who are only using stimulants, you can have a situation where someone, and we've had this happen in patients come into the ED many times for this, where they're expecting to use a stimulant and they actually have, either they're using pure fentanyl or they have something that's contaminated with fentanyl. And so then they go down and no one is really clear on what just happened, because it's an unexpected overdose. And so that's when you want to do, so stimulants, this is a great, patient education moment where you can talk about how stimulants are often can be contaminated with fentanyl. And so that's when you want to use your fentanyl test strip. So that's why we're encouraging people to use the newer test strips that are available from Dance Safe, because they don't have the problem of getting the false positives. Next slide. So why do we have a picture of someone wingsuiting? Because anyone who's using substances from the street is really out there in terms of danger and harms that come from overdose. So we don't know. We're going to enlist universal precautions. We're going to always assume fentanyl is in everything that you can get from the street, whether it's a pressed pill, whether it's a powder, whether it's a rock form, whatever is out there, we're going to assume that there's a presence of fentanyl. So that's our messaging to patients, is kind of have that mindset, always carry naloxone, go low and slow. So we want our patients to, not, anytime they're using any substance that they want to just, you can always take more, you can't take less. And avoid using alone. So Never Use Alone is a service where you can actually call this 800 number, and they will stay on the phone with you, and they'll basically ask a few basic questions, mainly where you are, and then they'll stay on the phone with you, and they will call 911 if you stop responding. And of course, taking turns, so not having everyone use the same substance at the same time, and then no one's there to call 911 or use naloxone. Next slide.
Josh, I have to say, I just read an article about Never Use Alone last night that I was really inspired by. It's just like you were saying before, and like Alicia was saying, keeping people alive. So yeah, all right.
Yeah,
Thanks.
I actually heard there's if you search around on the internet, there's actually audio recordings of someone one of these encounters, and it's really powerful to listen to. It's like it kind of gets you. So for naloxone distribution, there's a couple strategies that have been employed. One, historically, it's been about co-prescribing or prescribing naloxone. And unfortunately, the impact of that has been incredibly limited, so much so that it's approaching zero. So the research number is that less than 2% of those prescriptions that are being prescribed are actually filled. So that is not the strategy we're going with. So what we're going with is a take-home in-hand approach. I mean, we want that patient to walk out of the ED with that medication in their hands, with a naloxone kit in their hands. And at our pilot site, we started with this is basically the numbers we were getting using prescribing. And in 2018, this was our baseline numbers. We were getting about 7 kits in hand per month, that they were actually going down to the pharmacy, filling up the prescription, and leaving our institution with naloxone. Once we started implementing low barrier take-home in-hand naloxone, so just passing it out, we 65x'd our distribution rate from that change. And so now we went to 452 kits per month, as opposed to 7 kits per month that were going home in hand. And that's where we started to get to a place where we could really push down the fatality rate in our community. Next slide, please. And this has really taken off. So again, in 2018, there was really no emergency department in the state that was doing low barrier naloxone distribution, and there were no kits for free distribution available from the emergency department in 2018. Fast forward to this year. So second quarter this year, we have 211 EDs distributing free take-home in-hand naloxone, and 180,000 kits, more than 180,000 kits. I think by now we've probably pushed over 200,000 kits that are available for free distribution out of the EDs. So it's been very popular. There's, as you can see, the EDs have really engaged in this, and a ton of kits are going out. And the dream that Ariana was alluding to, where the ED safety net as a real 24/7 hub of harm reduction is being manifested. Next slide. There's a lot of knock-on effects of having the ED engage in this. So we've had 12 local community programs that began naloxone distribution as a direct result of the pilot program. So because the EDs are prominent in the community, so we normalized naloxone distribution, and we were able to get these 12 community programs that were engaging with very high-risk populations, but not at all providing naloxone. They were not part of that, and now they were. And we were actually able to, we directly gave these organizations from the ED, we gave them parts of our supply so that they could redistribute from their institution. So these people who were these are homeless service agencies, law enforcement, we had an adjacent children's sickle cell program, on and on and on. So all these nonprofits and community organizations that really didn't have the bandwidth and the impetus to get started with this were able to use sort of we were a catalyst for them to begin engaging in this work. Next slide.
And Josh, I was going to say, this has been the same impact in my community. We started distributing, and distribution is different than dispensing. We have it in a cabinet, and we just low threshold. We just give it. Somebody says they want it because their kid may be using drugs. They get it. They don't have to even be a patient in our emergency department. But that low threshold model, I do that now. I work in an addiction clinic. Actually, I work in a primary care clinic doing addiction medicine in a very rural area of my county. And we do this, we're just distributing it like crazy. And I got my other primary care clinicians to do the same thing. So if you're interested in all of this, we have tons of resources. I can tell you, this crew that's on this presentation today, we have been very passionately coming up with resources to answer the questions that have come up over the years, so that there's an easy answer for you in an easy way. I always say, if you get stuck, there's a way here in these resources to unstick yourself. Next slide. We are creating a movement. Join us. We want a movement of low threshold, lots of access points for treatment for opioid use disorder across the country. We would love to see Kentucky. Also, I know you're working really hard on developing systems of care. This can be done. It can happen. Look at what we're doing in California. You can do this anywhere. And I already see from a lot of the comments from Dr. Allen how much you've done to make this easy access. So join us, join the movement. This next slide, I want to hear from you. Please, I would love, Dr. Allen, maybe you can help us figure out some of these questions that you think are important for us to answer with this really talented and passionate crew here today.
Well, thank you all so much. Such an insightful presentation. I'm always so impressed when I hear about this model, the outcomes of this model. It's truly a testament of how we can make a substantial shift in our systems to impact lives and save lives. And so it's certainly a timely presentation. As was noted in the chat by Commissioner, our state is working toward positioning our hospitals throughout the Commonwealth to develop and support a similar model in emergency departments. And I know there were a number of questions that filtered through during the talk around how we can make this happen. And so I want to tap into a few questions. I know we touched on stigma. We know that medications for opioid use disorder is considered the gold standard of treatment for opioid use disorder. It, of course, is also a decision between the individual and their treatment provider, whether or not they choose to engage. There is no single pathway to recovery, but we know that there's research that shows there's numerous benefits to utilizing medications, improved outcomes for individuals that utilize medications, but there's still this abundance of stigma related to MOUD. Again, that misconception that we're replacing one drug with another. Perhaps hospital administration doesn't trust or want their staff to prescribe the medications, as was one of the comments made in the chat. And so given that this, again, is something that we're hoping more of our hospitals will be uptaking in the near future, how would you suggest that, that starting point again? How do you engage and get that buy-in from hospital leadership, at least to start?
Maybe I'll start out with this just because I did a lot of work in my hospital. Because again, I started out, I actually was afraid that people would find out what I was doing because I was an early adopter. So this was in 2017. And actually what I found is we kept data of how many people we were starting and continuing on buprenorphine, and we told stories. So I'll start from things that anybody on this call can do, which is just tell stories. So Alicia talks about this all the time. Sometimes these stories, I know one site that I support, they at their emergency department meeting, which most of us have an emergency department meeting of sorts, either with the providers or like an emergency services committee, is they would just give 2 to 5 minutes every meeting to tell a story of somebody they had started in treatment for opioid use disorder and the outcome. And those stories, if you have a connection with the clinic that's where people are following up. I always say in the emergency department, we often don't see the people who are doing well. I saw one person yesterday who came in because he just lost a prescription, and that happens. And he looked, I couldn't even recognize him. He looked so great. And he was so grateful when I said, wow, I mean, just seeing him 6 months later after we had initiated buprenorphine in our emergency department, he was using opioids, alcohol, methamphetamine, and really high dose benzos. And he was off of everything because of that one act in the emergency department of giving him buprenorphine and connecting him to care. So telling those stories can be really impactful. I actually brought more intention to this in my hospital because I surveyed people who use drugs. And tell me, I asked them to, we did some surveys and tell us about your experience in emergency departments. There's some people who do a lot of this work. So reading about this, and they were saying, if one person in the hospital looks at me like I'm a lesser human, I'll leave because I'm already feeling bad. And so if somebody is, I can see that they have stigma, I might leave. So I did a stigma intervention. We have a resource for this at bridgetotreatment.org in my own hospital, where I took this head on. We included it in skills lab for my emergency department nurses, but we also brought this to registration, to security, to every staff member in our hospital. And we did a perspective taking exercise with my navigator telling her personal story, so that people could relate to it. But we didn't just leave it there. We talked about the neurobiology of addiction and normalizing addiction treatment as part of medicine. And then we talked about what we do about it at our hospital, so people are on the same page. And that had an enormous impact. We actually, to Josh's project, we saw an immediate increase in distribution of naloxone, an immediate increase in identification of people with opioid use disorder. And I really think it's because it's the way that we were talking to people. And if you don't have the bandwidth or ability to do that, simply changing your own language and the way you approach people who use drugs. Nurses tell me all the time, they see how I interact with people, the kinds of relationships I form with patients. I had a patient yesterday who told the nurse, please tell her, this is a California thing, please tell that, she said, tell Ariana she's rad. And you know why? Only because I treated her with compassion and respect. So I modeled that, then people get feedback on that, and you can see a change in your emergency department. So you can go from really small to changing your own behavior, your own language. You can tell stories at your meeting, that would be kind of in the middle, to even doing a whole educational project where you get everybody in your hospital on board. Thank you. Anybody else want to add to that?
I would just toss out, there are so many questions in the Q&A, and I think Josh and I have been doing our best to take a stab at answers. So for a lot of you who maybe have questions, if you look at those that have been answered in that Q&A tab, hopefully there's something in there for you. A lot of it is like technical medical stuff, which if that's what you need, we're here as a resource. Like Ariana said, please reach out to our team. But if it's other stuff like, how do I do this? How do I get started? One patient at a time. You just do it. Just pick an ER, treat a patient. And once people see the success, it is much, much easier to sell the cause. But these stories only come from just trying it, just getting someone to try it. And it really does change lives.
Yeah, I'll say a comment on that. I remember once I just, somebody was trying to treat a person in withdrawal with just like clonidine and kind of the old stuff that we used to use by itself. And I had just made the suggestion we give this patient buprenorphine because they were suffering. And so we did. And then the person just immediately just felt normal, was really grateful, was hugging the nurse. It's pre-COVID. And the nurse came by and said, we just saved that person's life. And so I think that just taking away all those barriers and just start doing the thing, it makes a big difference. But Jean, I see have your hand up.
Yeah, thanks. One thing I found that was helpful with training paramedics and the EMS community was when we did our initial training, to normalize it, I basically asked everybody, who here hasn't had somebody they know, somebody in their family, or a friend have a substance use disorder? Once you start thinking about yourself, your family, your relatives, your community, it's there. And that normalizes it to say, yeah, it's not just some random person on the street that we're trying to, oh, we've been there a bunch of times. You're like, oh, this is like my friend William, or, my cousin who, has been struggling with this for a long time. And that normalization, I think, was super powerful. And they were starting to look at each other like, oh yeah, totally. This totally makes sense.
Thank you all for those comments. I think one of my follow-up questions is going to be, there was a question around how our emergency departments are already overwhelmed. And so what were some of the key challenges that are experienced when startup happened in terms of implementing this model, and how long did it take? What was that timeline like in terms of implementing and streamlining this model?
Happy to start this out, and I'll give it to Alicia afterwards. I can tell you that every single emergency department that I talk to across the country will say that they're overwhelmed, including my own. So it's not it's a thing. We're all overwhelmed, and actually, emergency departments take care of. I just looked at an article that take care of more than 50% of all medical care in the country. So no wonder we're all overwhelmed, where people are choosing that way because of the nature of it, because it works. People want 24/7 access. So we could either fight it, or which has not worked. I've been practicing for 24 years, or we can actually do a better job with what we have. So when my navigator and my team is involved with a person who uses drugs, we reduce readmissions 5 to 10-fold. We decrease length of stay. We now treat opioid use disorder rather than treating with IVs and with people not telling us that they're in opioid withdrawal and getting CTs and doing unnecessary testing. We treat people in fast track. People are able to get people treatment from our waiting room, and it works. So it's not just quick treatment, it's quick treatment that changes their life. So it's actually, how often is doing the right thing that's evidence-based the easiest thing too, the fastest thing, the thing that makes the most sense. So I'll start there with every single place I've worked with this said, but I can't do this because I'm overwhelmed. And we say, well, you should do this because you're overwhelmed. So, but Alicia, I'll turn that over to you.
Yeah, I think, oh gosh, I was a director of a department actually for a couple of years, and I've been an ED doc for like 10 years, and I agree. I don't want another initiative. Like, I don't want the ER to solution for anybody else's problems. It's really hard. What I think is important to realize is this is already an ED problem, and you're not actually pitching a new initiative. You're helping your emergency department update to the standard of care. And so I think that's the approach that we often take when we're working with a new hospital, is we tell the doctors, this isn't a metric, it's not a new project. This is, medicine has moved forward. We are filling your educational gap and helping your ED provide life-saving evidence-based care, which will happen to also make these encounters easier. You will be happier, and the patient's length of stay will be shorter. And so when you tell people it that way, and you focus on, this is education to update your practice, not this is an initiative. It's not an initiative. It's the standard of care. And we're just trying to make sure everybody catches up. I think that angle is really important. And I'm not just saying it to say that, it's what we believe as well.
And to honor physician, PA, nurse practitioner time in doing this, there's a procedure code, G2213. So it pays out pretty well for productivity if there's people on this call who are paid by productivity. So it's a Medicare code. So we're trying to meet all of the, like I said, there's a lot of reasons to do this. And again, it's making things easier. So it was an enormous difference in my emergency department, because I had people who were, not everybody in my rural emergency department was really excited about this, shocker. And yet everybody now has become an expert and does this because it is the easiest thing to do that works for patients.
Wonderful. Thank you all so much for answering those questions. And I still see more questions coming in, and I appreciate you all. If you can stay on just for a few minutes longer to help address some of these questions, that would be wonderful. If we're not able to get to any of these questions, please do know we'll try to send them off to our presenters so that they can address those for our attendees later on. I did want to note is some of the pieces that were in the chat. I want to make sure that I highlighted that for our attendees, just making sure, we're obviously done an incredible job in Kentucky improving distribution of naloxone throughout our communities and through our hospital systems as well. It is a Medicaid covered benefit, so I do want to make sure that that is made clear for those on the call. So of course, ensuring that encouraging that to be prescribed to those that need it, or perhaps even have loved ones that need it. In addition, fentanyl test strips are no longer considered drug paraphernalia in Kentucky as of July 1. So yes, wonderful news. So do know that that is a legal resource here in Kentucky now. I know they're being distributed through our local health departments and other community agencies that distribute naloxone kits and other harm reduction supplies. So FTS, fentanyl test strips are legal. Yes. Okay. So with that, since we are cutting it in on time, and I want to make sure that we have plenty of time for our next presenter, which if you haven't had the opportunity to hear Dr. Alex Elswick present previously, you are certainly in for a treat. This afternoon, Dr. Elswick is a tireless advocate for people with substance use disorders. He currently serves as an assistant professor and extension specialist for substance use prevention and recovery for the University of Kentucky. He is a trained researcher, recovery coach, mental health therapist, as well as co-founder of Voices of Hope, a peer-driven recovery community organization in Lexington, Kentucky. And Dr. Elswick himself is a person in long-term recovery from the chronic disease of addiction, and he has an incredible testimony. Dr. Elswick, thank you for joining us.
Thank you so much for having me. And I know that's kind of the patented thing to say at the beginning of a presentation is like, good morning, good afternoon, thanks for having me. But genuinely, thanks for having me. It's an honor this time to be here. I get the chance to do a lot of speaking and presenting, but this one's meaningful to me personally because early in recovery, I was really fortunate to get to go back to school, and I started learning more about addiction, and I was just hungry to learn as much as I possibly could. And I started attending the Kentucky school, and it was the coolest thing I had ever seen. And I thought that the presenters, the researchers and the clinicians were just gods, and they were so brilliant. And I was just desperate to be like them and to get the opportunity to help people improve their understanding. And that's what we get to do today. So that's pretty cool for me and pretty fitting. And then also I'm celebrating today. Today, September 13th, is my 10-year recovery birthday. I'll tell you all this in just a moment, but September 13th, 2013, I was walking out from under a bridge and into a homeless shelter. So I've spent a lot of just this morning, honestly, in reflection, thinking about the last 10 years and thinking about the enormous list of people who have helped me. And that's kind of what I want to talk about today, are all of the things that help. What the research, what science says are the ingredients to the recipe for recovery, the puzzles, the pieces to the puzzle that need to be in place so people can sustain it in a meaningful way. And you may have heard, if you've been in one of my presentations before, you may have heard pieces of this or something similar, but I would ask, even for the old heads who know all that there is to know and you've been around, to hang in there and stick with me, because I heard somebody say not too long ago that insight is merely a rearrangement of fact. And I like that. That makes sense to me. And so maybe what we're going to do today is I'm going to talk about a lot of things that you already know, but maybe I'll talk about them in a different way and connect them and give you some new insights. And so that's kind of the hope for today. Really quickly, by way of introduction, I do not want to spend a lot of time here, but I am, as you heard, an assistant professor at UK, which means I get to teach in the classroom about drugs and drug addiction and people who use drugs, most importantly. I get to do research mostly focused on long-term recovery, but then the majority of my job is exactly what we're doing today, which is research translation, being like all the people who were my idols at the Kentucky school. So pretty cool. As you heard, I'm also a co-founder of Voices of Hope. I'll make a shameless plug for Voices just a little bit later on. I have clinical experience as a marriage and family therapist. You know, I learned a lot you learn different things from clinical experience than you do from on-the-ground service provision, than you do from the research, and certainly than you do from your own personal experience. And occasionally I'll give a presentation where I don't share some of my own experience, but I always feel remiss when I don't share, because it's important, and it's especially important to what we're going to talk about today, to frame the discussion for today. And I brought you all pictures, which always makes things a little bit more fun. So I'm from Lexington, Kentucky, born and raised to the most fortunate circumstances, wonderful parents, wonderful life. I grew up, privileged in the suburbs. Nothing bad ever happened to me. But I inherited risk factors, a genetic predisposition for addiction, quite a few anxiety disorders. And I ended up getting addicted to prescription opioids when I was 18 years old, and I had my wisdom teeth removed. And this is approximately 18-year-old Alex. And it's okay to laugh. If you're laughing at home on your computer, it's perfectly acceptable. I went through a 5-year period of my life where I wore nothing but flat bill, baseball caps, and white tees. I think I was trying to shed my privileged upbringing a bit or something. I don't know what. I got addicted to opioids, and addiction took me all those bad places that people go in addiction. My story's not really all that special as addiction goes. I went to jail on drug trafficking charges. I went in and out of treatment centers. And I mean in and out of treatment centers. And the thing that I want you all to understand most about my experience is that I was trying. As I was trying just as hard when I was returning to use after a 30-day treatment center, trying just as hard as when I was in long-term recovery, trying just as hard as I have to today. I think in many cases, we create this artificial division where we say the people in recovery are the good ones and they're the worthy ones. And they're the ones who are honest, open-minded and willing and worthy of help. And the ones who are in active addiction are the ones who just can't get it together, or they're just not willing to be honest with themselves, or however we moralize that. And I don't think that's right. That didn't fit my experience, and it doesn't fit my interpretation of the research either. I kept going in and out of treatment. I kept returning to use, even though I didn't want to. And I ended up through a long series of events experiencing homelessness in a number of different cities. This is the Highway 35 overpass that runs through downtown Dayton, Ohio. And I experienced a lot of the bad things that people experience when they're homeless. And on September 13th of 2013, 10 years to the day, I checked into a Salvation Army, which is a homeless shelter there in Dayton, and started my recovery. And I always tell people, first 30 days at the Salvation Army are the worst 30 days that I've lived on planet Earth. And it's just so much easier to be in active addiction. Even if you're under a bridge, when you're out there, you can get your hands on your medicine, you can have a respite from the way you feel. But early in recovery is misery. And I struggled, and I ended up spending 6 months there. Things slowly got better, but I really tell you all of that, and I fast forwarded through that so I can tell you this last piece because it's most apropos to what I want to talk about today. When I left the Salvation Army, I left with all these barriers that are characteristic of a person leaving treatment or leaving incarceration, because I had bad credit, and I had lots of debt, and I had a criminal record, and I had no college degree, and I had no marketable skills, and I got on food stamps, and I was disqualified from most forms of supportive housing by virtue of the fact that I had a drug trafficking charge. I didn't know where I was going to go. I didn't know what I was going to do. But the reason that I take pains to talk about coming from a privileged experience is because it matters. That's not just virtue signaling. I'm not trying to say, hey, look at me, I'm a good guy. I'm telling you, it completely framed my experience. And what I mean by that is, my buddy Jason, for instance, who's going to be in my wedding, by the way, graduated the Salvation Army with me. And after doing 6 months of the hardest work of his life, he didn't have the family support that I had. He didn't have the financial support that I had. So he had to go continue his recovery at the Gateway shelter in Dayton. And that's the shelter where folks are shooting dope. And we don't have to be a call full of 700 addiction experts to go, hey, probably not a good environment for your friend to try to sustain recovery. And I didn't have to do that. And I want you all to hear this. I didn't have to do that. And it's not because I'm better than Jason. And it's not because I worked harder than Jason. And it's not because I was more honest or more open-minded or more willing. It's not because I wanted it more. It's not because I love my family more or I was willing to make more sacrifices. It's because I had help that Jason didn't have. My dad had a relationship at a church in Lexington. And as a result of that relationship, they let me sleep at the church parsonage for free. Can you imagine the amount of biopsychosocial stress that is reduced? I guarantee there was a measurable decrease in my cortisol levels when I knew that I don't have to worry about making rent. Instead, I can marshal my energy, focus my resources on my recovery, where it should be, right? Most people in my position, they leave treatment, they leave incarceration, and they go pound the pavement and they submit job applications to jobs that are humiliating. And that's not a knock on any type of job. It's humiliating for them, given what they're capable of. You all know as well as anyone that people in recovery are really capable, really competent people. But because of the stigma, I heard you all talking about stigma a moment ago, because of the stigma that gets imposed by society at large, it gets internalized into this self-stigma, these self-limiting beliefs that says, well, I use drugs, so I flip burgers. And I didn't have to do that. And it's not because I'm better than them, and it's not because I'm smarter than them, and it's not because I worked harder than them. It's because my dad's a doctor, you know? I'm a Nepo baby. My dad's a doctor. My dad had a patient who'd gone through a mental health experience similar to my experience with addiction, and he gave me a job. And it wasn't a job that I earned by merit. It wasn't a job that I earned with an illustrious resume or a CV. It was a job that was given to me. But then when I had a job, I had health insurance. And then when I had health insurance, I could see a therapist. Like so many of you fine clinicians on this call, then when I could meet with a therapist, I could address my anxiety, which is somewhere near the root of my addiction to begin with. And so when I got to graduate school, I looked back on my experience, and I've always been asking myself variations of one central question, which is, why am I here? And so many of my friends are not. And I've heard lots of stories. Lots of people will tell you different reasons. Well, you earned it. You worked for it. You were willing to sacrifice. A lot of moralizing narratives. And I just happen to know that those things aren't true. When I reflect on my experience, what I realize is I had access to infinitely more than most people have access to. And it made all the difference in paving an easier way for me to sustain recovery. I could go down just a ridiculous, exhaustive list of things that I had access to. And that stuff is the stuff we call recovery capital. And so those of you who you've ever heard me share before, you know I go on and on about recovery capital. It's the stuff of recovery. For so many of us, we think of it as an afterthought, and it's not. It is foundational to any healthy human being, especially someone in recovery. So yeah, 10 years hence, a lot has changed. I show you all of my shame, so I want to show you just a couple of moments of my pride for just a second. Did a lot of damage in my relationship with my family. Unfortunately, a lot of you all know how that goes in active addiction, and I'm really fortunate. I don't get tearing up too often, you all. I'm just really fortunate that I have a mom and dad who saw it through with me, and so sorry, you all. Every Wednesday, we would meet at the Waffle House, at the Awful Waffle, to just reconnect. And that's like hallowed ground for me. I should take my shoes off when I go into Waffle House, but I won't, don't worry. It's just a really meaningful place to get to reconnect and do recovery. And this is our staff at Voices of Hope circa like 2017 maybe. And since then we've expanded to over 100 people in recovery who use their lived experience to help other people in recovery. It's the coolest thing I've been a part of, and I'm a very small part of it, but I'm glad to be along for the ride. And then lastly, I always tell people, I don't know if I'm putting this up to legitimize the discussion we're about to have, or if I'm just putting it up to brag, because I might just be bragging. But the highlight of my life was getting the opportunity to go on stage and talk about the importance of recovery capital with some of the giants in the field, Nora Volkow, the director of NIDA, Francis Collins, the director of NIH, just the coolest thing in the world. And Dr. Sharon Walsh, the PI on the Healing Community Study. So it was just really, really an honor. And I think speaks to the importance of what we're going to talk about today. So I always like to start after sharing personal experience by grounding us momentarily in the brain. We're not going to do a whole neuroscience or neurobiology of the brain. That's really not my expertise anyways, but I think we'd be remiss to talk about a brain disorder without talking about the brain at least a little bit. And so here's your real quick reminder. This is neuroimaging called a PET scan, a positron emission tomography. And basically what we're looking at is dopamine activity in the brain. And so we know that in the short term, when a person uses drugs, it leads to spikes in dopamine, hence the euphoria. But over the long term, through chronic, repeated exposure to drugs, it leads to this homeostatic response. What goes up must come down. And so dopamine down regulates over time, where dopamine levels go down, 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 until you have a brain that looks essentially like the brain in the middle, which is what an addicted brain looks like. But I'm kind of being sneaky here, because that brain in the middle is not actually an addicted brain, or someone with a substance use disorder. I should say that's someone with a substance use disorder who is a month in recovery. So for the sake of argument, we can imagine that's a person who's just graduated a 30-day treatment center. And think about what the term graduation suggests, what it implies. It implies that you're finished, you're done, you've done the work, good job. Now go be free. And the reality is, that doesn't reflect the reality at all. That's a completely and utterly addicted brain for all intents and purposes. That brain is nowhere near restoring sufficient levels of dopamine to have reordered or properly ordered decision-making. And so you look at the brain on the far right, that's the brain of someone who's 2 years in recovery, and that brain much more nearly approximates the healthy control brain. The point here is this, not to get bogged down in neuroscience. The point is to connect two ideas. One, that addiction is a chronic disorder. So even though for years, for decades, we've tried to treat addiction as an acute disorder, episodically, where we just send people to short-term treatment centers over and over and over again, the reality is what the preponderance of the evidence would show is that substance use disorder is a chronic disorder. And the implication of that is, if this is a chronic disorder, then what it requires is not just short-term treatment, but long-term chronic disease management, the same way we manage any other chronic disease, right? And it also means that recovery is a process. It means necessarily that recovery is nonlinear, that it's not as if people decide today I'm so tired of the consequences that I'll just stop using. Because if they're able to do that, then by definition, they really don't have a substance use disorder in the first place. And it helps us understand that people can be trying and failing at the same time. And it's one of the themes that I just want to return to today. It's been what's been on my mind the most, is that we're doing such a good job destigmatizing recovery, but we're not destigmatizing people who use drugs and people who are still struggling in their active addiction. And we're still casting them as the bad guys. And it's got to stop. It's an artificial division. So chronic disease requires long-term care. So what does that look like? What does it look like? Chronic disease management. That's what we're going to talk about. And so this graphic from CORE, the cascade of care, I think is so brilliant because there's a lot more going on here than first meets the eye. And we'll even add to this a little bit later on. But the reason I like it is because the hexagons at the top represent what we think of as the most conventional or traditional buckets in terms of our approaches, our strategies to address substance use. So generally we think of like there's health promotion, prevention, treatment, and recovery. And so that's where we write our grants to funnel our resources and marshal our energies. And what we've often overlooked is the reality of recovery capital. This stuff that we think of aftercare as an afterthought, when in reality, this is foundational, not just to the health of somebody in recovery, but to the health of somebody, of a human being, right? So let's touch on recovery capital really quickly. My favorite way to describe recovery capital is think about other times that you've heard the word capital. So it could be social capital, it could be financial capital. Capital means resources. And so in this case, recovery capital is referring to recovery resources. And it's this sort of umbrella term for thinking about the many vast and varied resources that improve the likelihood that a person will sustain recovery. I think oftentimes if you just say it to someone in the general public, what do people need to get better when they're addicted? People will say, well, they need rehab. And for many of them, that's kind of the extent of their understanding. And the reality is most people in recovery don't access formal help, something that we're going to talk about. And it speaks to the need for them to access recovery capital instead. So recovery capital is a broad umbrella. You know, having stable housing is recovery capital, having access to health insurance, a primary care provider, a dentist, you know, all these things that maybe we think of as really secondary, like let's get them to treatment first and then we can address their teeth. But imagine trying to recover when you're really ashamed of your teeth, right? That's a serious psychosocial challenge that's going to limit your ability to be employed, your ability to find a partner, your ability to raise your kids, your ability to build self-esteem. This stuff is fundamental and it's important. And I like to set it aside or beside Maslow's hierarchy of needs, because even if recovery capital is a totally novel concept to you, probably Maslow's hierarchy isn't for many of you on this call who do stuff in the social work space, in the clinical space. So I put this up for a couple of reasons. One, because Maslow used the language of reaching one's full potential. And as I'll show you in a moment, that's the same language, almost verbatim, that we use, that SAMHSA uses for the definition of recovery. And so in many ways, I think of Maslow's hierarchy of needs as a hierarchy of recovery. It helps us kind of recenter on what are the things that people need to be healthy. Because at the end of the day, people who use drugs and people with substance use disorders are people first, more alike other humans than unalike, right? We take that for granted sometimes. And so Maslow said, you know, your needs have to be met, but they have to be met in order. Your most basic needs have to be met first. And I think that's intuitive. That sort of goes without saying. It's like, you know, those of you who have kids or have ever worked in an education space know that your kid can't go to school and learn and engage and be social if they don't have breakfast in their belly. And if they didn't get a decent night's sleep the night before. That's basic. That's 101 stuff, right? But for some reason, we kind of forget that when it comes to people with substance use disorders. So fundamentally, the way that recovery capital works, the reason, so if you were to say, why is it that recovery capital is important? Because it reduces stress. And by reduces stress, again, I don't mean like, oh, I had a stressful day at work. we're talking about that really meaningful kind of biopsychosocial stress, the kind of stress that says, I might get evicted on Friday and I have 2 kids and I don't know how we're going to put food on the table, and it's raising my cortisol levels, which is compromising my physical health and my mental health. It's compromising my ability to parent and my ability to work, right? That's the kind of stress that we're talking about. And recovery capital mitigates that. The safer your housing, right? The more secure your employment, the more money you make, the better your relationships. All of these things insulate you from that would-be stress that leads to a return to use. And I think the reason I like to start here with Maslow is because we all agree. I think most of us go, yeah, this is pretty obviously things that people need to sustain recovery. But this is a point where we may not agree. And so here's the main tension that I wanted us to explore today, is when should we start providing those resources for people? Should we start providing access to recovery capital? Do we start facilitating access to those resources right now, today, as soon as we can? Or do we need to get people abstinent first? Do we need to make sure they get sober so that then they can be good stewards of those resources? And I want to suggest to you all, and you can reflect on this for yourselves and within your own communities, I want to suggest to you all that in Kentucky communities, we've answered this question, and we've decided that people have to become abstinent first before we're going to facilitate access to the vast majority of recovery capital. And so I'm going to go through a few examples, and this is by no means an exhaustive list, but housing is in many ways the preeminent example. In fact, one of our community advisory board participants at Voices of Hope, whose name is Laverne, just wrote an op-ed for the Herald Leader related to this very thing. We don't have housing for people who use drugs. It doesn't exist. Our emergency shelters don't allow people to be intoxicated or to be possessing drugs. It means if you're a person who uses drugs, you actually don't have housing in many cases. We have sober living, but as you all know, sober living is not a place where you can go to become sober. It's a place where you have to pass a 12 panel as soon as you walk in the door. And let's say you do. Let's say you're abstinent and you pass your, you test negative on your 12 panel urinalysis, and 3-4 days later, you experience a return to use, right? And you experience a return to use because, as I remind you, you've got this chronic disease, right? It's not a choice that you made. You didn't decide that you wanted to use again, but you've got a chronic disorder and you used again. Well, in 99% of cases, what we're going to do is we're going to kick you out of your supportive housing. We're going to kick you out at precisely the moment that you need it the most, because we're more concerned with abstinence than we are with your health and wellness, with recovery broadly written. Caregiving is another example, and I always want to tread lightly because I don't want to give anyone the impression that I'm being critical of family members, because I have no desire to do that. I think concerned loved ones and family members do the very best they can with the information they have. What I mean to be critical of is people like me, us in the field, who have done such a poor job of giving, useful clinical guidance to family members on the difference between enabling and supporting. Because we tell family members your loved one needs to hit rock bottom, and we don't operationalize that, and we don't define that, and we tell them that if you enable them, then you're going to prevent them from hitting their bottom. And what we encourage families to do is to provide fewer and fewer resources, less and less access to recovery capital. And in the interim, many of my friends, as they're being deprived of the things that they need, are overdosing and they're dying while we're waiting on them to hit some kind of a bottom. In many cases, abstinence becomes a precondition for mental health services. Again, so what we mean by this is people have to be abstinent in order to access these services. And I know this personally. At the clinic where I was trained, we had a policy that said, even if drug use wasn't the primary presenting problem, if drug use was mentioned at all as a part of the initial call, that individual with the substance use disorder would have to go and show evidence of treatment completion prior to participating in family therapy. And so I bet you all can reason this out on your own. What do you think was the real world impact of that policy? Was the impact that a bunch of people went to treatment and got abstinent and came and saw us for family therapy? Heck no. That policy meant effectively, we don't work with people who use drugs. We don't serve families where drug use is a problem. It's effectively what that policy meant, because we were more concerned with abstinence than we were with the health and wellness, the autonomy of this entire family. And then probably the most absurd example of this, in my view, and you don't see it until you see it, and then once you see it, you can't unsee it. William White wrote a paper way back in 2005, and the title of the paper was like, "It's time to stop kicking people out of addiction treatment." And essentially what he argued is that substance use disorder is the only disorder for which the patient is blamed when the treatment doesn't work. It's the only, I mean, it is truly the only condition that I'm aware of where the patient is blamed when the treatment doesn't work. And it's awfully convenient. Whether we do a good job or bad job treating you, whether or not we give you access to evidence-based care, if you return to use on the other side, we can just really conveniently say, well, he didn't do the things we told him to do, right? When I go to treatment, what I'm implicitly acknowledging is I can't control my drug use. That's sort of what characterizes my addiction, right? And so let's say 2 or 3 days into treatment, indeed, I can't control my drug use and I use a drug. Probably what's going to happen is I'm going to be kicked out of treatment. I'm going to be kicked out of treatment for becoming symptomatic with the disorder that you already knew I had the day that I walked in the door. I'm symptomatic with the disorder that you're claiming to treat, right? And now you're kicking me out for having those symptoms. It's pretty backwards. And then I heard some of the discussion earlier as well about the stigma surrounding medications for opioid use disorder and some various harm reduction approaches. And in that vein, abstinence has become so synonymous with recovery, or maybe I should say recovery has become so synonymous with abstinence, that people who take any other pathway of recovery don't experience full and total acceptance by the recovery community. And it's a shame. Because, you know, the reason that we go to church basements for 12-step meetings is because we can't do it out in the general public. There's so much stigma. People don't want us around, right? And so we get tucked into the margins. And so imagine what it would be like to get tucked into your margin, to go to your church basement, to go to the one place where there are people like you who can support you. And you get down there and they tell you that you're not really in recovery. Even though you have meaningful employment, and even though you have custody of your kids, and even though you serve on 2 boards, and even though you're on the PTA, and even though you do everything that every other measure of recovery would say is recovery, they say, well, you're not in recovery. And as a result, they don't experience acceptance, they don't experience support. Abstinence, in an ironic way, I mean, maybe this sounds ironic to say, because it seems like abstinence is only always a good thing. And it is. I have nothing against abstinence. If I could choose for everyone, I would choose abstinence for everyone, because it is the ultimate form of harm reduction. It's the safest kind of recovery, but I can't choose for everyone. And that's the point. So if you're a person who subscribes to rock bottom, if you're a person who really deeply believes that people need to suffer more and suffer more and suffer more in order to recover, then I want to suggest to you that maybe you don't agree with recovery capital, and maybe you don't agree with Maslow's hierarchy of needs, because you've got Maslow upside down. What you're asking people to do is you're asking people to recover without the benefit of access to all of the resources that the research has told us would help people recover. It's pretty backwards. And then when people aren't able to recover because they've been denied access to these things, you know what we do? We blame them and we shame them. And that is dark and morbid as it could be. So here are what some of the experts have to say about rock bottom. Keith Humphreys was a senior advisor to the Obama White House from the National Office of Drug Control Policy. And he said, it's remarkable that people believe what's needed is more punishment. If punishment worked, nobody would be addicted. It's a pretty punishing experience. I agree with Dr. Humphreys, and I would say that no one, not my parents, not my friends, not the criminal legal system, no one could punish me as severely as my brain punished me by downregulating dopamine, right? That's the punishment. There's a special word for it called anhedonia. That's how miserable it is. You know what I mean? That's the punishment. And then William White, who I alluded to earlier, who's just one of my favorites, describes a moment when someone was explaining to him that rock bottom isn't what he's been taught that it was. And the guy says, Bill, you're not getting it. My clients don't hit bottom. My clients live on the bottom. Their capacities for physical and emotional pain are beyond your comprehension. If we wait for them to hit bottom, they'll die. The issue of engaging them in hope is not the absence of pain, it's an absence of hope. And so part of the question that I'm putting to you all today is really about your theory of change. Is really about fundamentally, what do you believe about why people change? Do they change when they've been punished and suffered enough? Or do they change when they have hope and when they have support? So let me give you some examples of what happens when we don't allow people to be in process, when we don't acknowledge the reality that this is a non-linear, sometimes circuitous route of recovery with fits and starts and returns to use. Instead, when we're laser focused on abstinence, this is what it looks like. My best friend and the man who's going to be the best man at my wedding, I share this with permission. His name's Bobby, has a substance use disorder, and he was arrested last year or a few years ago. This was a few years back, on cocaine charges, and got into drug court. And he told me, I'm not going to be able to be abstinent. I can't do it. I just know that about myself. I can't be abstinent. It doesn't matter how much I will it. It doesn't matter how hard I choose. I can't. And I know that because that's what my experience has taught me. And I said, well, Bobby, we got to give it a shot because it's a whole lot better than rotting away in a jail cell for a year. That's certainly not going to help you. And the thing that I know about his experience is he's been a victim of gun violence. And he has a lot of unresolved trauma regarding that gun violence. And what he really needs is an opportunity to build a rapport with a therapist and over time, in process, work through that trauma. But instead, what would happen is every time he would test positive, the court would immediately force him to go into inpatient treatment, which prevented him from accessing the kind of therapy that he needed to address his problem. So it's just a small example. I don't want to be too critical of anyone because I know, don't throw stones, right? And I really mean that. I really do feel that way. But I think it's a clear example of the system becoming more focused, prioritizing abstinence above what I would call recovery. Another example comes from MOUD providers, and I'm hopeful, maybe you all can comment on this in the chat. I'm hopeful that this is no longer the experience, but I know that this did happen early in my recovery advocacy, that MOUD providers would have someone who's been on buprenorphine for a long time or for a period of time, and they're experiencing stability and experiencing recovery, experiencing the fruits of recovery. And for whatever reason, maybe 6 months or a year into their treatment, they test positive for THC, and they might be kicked out for non-compliance. And it's my hope that that's no longer something that's happening, but it is a really gross example of abstinence being prioritized above health, above wellness, above life, because we know that to take somebody off of that medication is inherently life-threatening, being that it is an inherently life-saving medication. And then the last example, again, to return to family members. We have a good family friend who also a wealthy family. They come from a well-to-do family, and they had access to all the recovery capital and all the resources. And they went to one of these really nice treatment centers where they have family week. And I love that. I'm a trained family therapist, so I'm like, heck yeah, let's get the family involved. Let's do systems. And they did a contingency contract, which is really common, right? And they said, hey, in order for you to live in our home, on the other side of treatment, you need to meet certain conditions. And one of those conditions is complete and total abstinence. And this will be the consequence. You'll be kicked out if you can't maintain your abstinence. And about a week or two after leaving treatment, her mom came outside in the garage to get something to drink and caught her daughter smoking a bowl of cannabis. And the way she describes it, even though it didn't feel right in her heart and in her gut, she kicked her daughter out in accordance with the contract, and her daughter overdosed and died that night. And I used to sit on these examples and not share them, and just talk about them amongst my friends because I didn't want to be exploitative or dramatize anything. But when 108,000 people die in a single calendar year of an entirely preventable phenomenon called overdose, it's time to just get past the way we feel and to start saying the truth, right? All of these examples of prioritizing abstinence over health and wellness, over the fundamental needs of the human being in front of you, So what we need to do is reprioritize, shift the focus a little bit. And again, I'll probably say this 2 or 3 times just so I don't get myself in trouble. Abstinence is great. If you're on this call and you're in abstinence-based recovery, I love you and I am proud of you and you're incredible. And I mean that from the depths of my soul. I have nothing negative to say about it. What I have negative to say is when it's the only kind of recovery pathway that's offered, because it's narrow, you all, it's really narrow. So a quick reminder, I think now is a good time to ground ourselves in SAMHSA's definition of recovery. It's a process of change. That's a phrase that I think most of us would breeze right past when we read this definition. But there it is, that point that I was making about chronic disease. That means recovery is a process. It means it's nonlinear. And it's this process in which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. What you notice is no mention of abstinence, no mention of drugs or alcohol, because for the experts at SAMHSA, recovery is not about the results of your 12-panel drug screen. That's not, when we think about the fruits of recovery, that's not what we think of. It's posting up all our negative drug screens, right? That's not what we think of. We think of healthy communities. We think of parents reuniting with their kids. We think of people reaching their career goals, right? These are the things that matter to us. These are the actual measures of recovery. Recovery is about health and wellness and autonomy, living an independent life, reducing associated harm. It's not at all about abstinence. And so now, if you look back, let's see if we can pull out something else that I think is interesting here. Because I think this is such a good diagram. What you notice is that recovery capital building doesn't begin at the point that a person is in recovery. It doesn't begin at the point that a person accesses treatment. Recovery capital building is something that we're doing all the time, always. And we should start now, not now, right now, yesterday. Start providing them with the resources that they need. Flood them with the resources that they need that predict recovery, right? So I want to take a step back just for a second. I always tell people I'm putting up the old crusty white men for a reason, because they're great, they're brilliant, and it helps to ground our discussion of recovery capital a little bit. I think sometimes when I talk about recovery capital and I get all animated and excited, I'm afraid people are only hearing me say, hey, people need resources. And a lot of you on this call are going to go, well, yeah, we knew that. But it's really more nuanced than that. The value of recovery capital is a little more subtle than that. And so I want to wade into that nuance. So William Cloud was working on his dissertation, and he was studying college students in the 1960s who had substance use disorders. And he noticed two things about the college students that he was studying that were different about what he was seeing in the general population. And the first was that they seemed to be recovering at a higher rate, which on its face just seemed to be interesting, maybe a statistical abnormality or who knows what. And then he noticed, as he followed these students longitudinally, that they were never going to treatment, and they weren't going to AA meetings, and they weren't even going to see therapists. They were just sort of like graduating and growing up and moving on with their lives and sort of just maturing their way out of addiction. And so he ends up writing this paper with Robert Granfield that no one has ever heard of, but I think it's really important. It's called The Elephant No One Sees, Natural Recovery Among Middle-Class Addicts. And the elephant that no one sees, the elephant in the room, the authors argue, is natural recovery, is this really important phenomenon that when I first read about this, I hadn't even ever heard of. I hadn't even ever considered as a possible pathway of recovery. Because to me, I was in treatment. All of the people I knew at that time who were in recovery had gone to treatment. Everyone around me had gone to treatment. So I just assumed that was the only way that people got better, was through treatment, right? And it turns out there's this huge swath of the population that recovers without formal intervention. And in fact, not only does that phenomenon exist, it's not an uncommon occurrence, it's the rule. So this might blow some of your minds. It blew my mind the first time I really understood this. And I think it matters. It has some important implications to draw out. The majority of people who recover, who are in recovery today, right now in the United States, recovered without formal help. They didn't go to a treatment center. They didn't go to 17 treatment centers either. They didn't go to a clinician. They didn't go to 12-step. They recovered organically. They recovered naturally. And it's sometimes called spontaneous remission, but I really detest that term because I think it's totally misleading. Spontaneous remission suggests that people get better because they spontaneously wake up one day and go, you know, I think I won't be addicted anymore. And of course, that isn't the way it works. People recover naturally precisely to the extent to which they have access to recovery capital. And so that's why I wanted to talk about these two things together to make a conceptual link between these recovery resources and natural recovery. If we actually do a better job of insulating our communities with recovery capital, we may have less need for primary treatment because sufficient recovery capital can completely preclude the need for treatment. That's a powerful statement. That, I think, is strong support, strong evidence that recovery capital is not secondary. It's not, hey, aftercare is an afterthought. This is foundational stuff, and it's stuff that people need access to right now, today. So I love to contextualize recovery capital by taking a step back and thinking about how we've addressed the addiction over the last 50 years or so. So really starting probably in 1914 with the Harrison Narcotics Act, but certainly in 1971 when Nixon declares war on drugs, we started waging a war on drugs. And I actually was just lecturing on this in my class on Tuesday and asking my students the question, when you wage a war on drugs, Where do people who use drugs fit into that war? Whose side are they on, right? And so inevitably, when you wage a war on drugs, you wage a war on people who use drugs. And that's what we did. We persecuted people like me, people like a lot of you, and it didn't work. All that mass incarceration led to no significant improvement in substance use outcomes. And so starting about 2000 to 2010, what we think of as the age of the brain, we started to understand the neuroimaging, the neuroscience I showed you earlier. And we said, oh, this is a brain problem. These aren't bad people who want to be good. These are sick people who want to be well. And so you saw the advent of all these progressive alternatives to incarceration: veterans court, mental health court, drug court. And that's a step in the right direction, right? I want to suggest this is essentially the model that we have now. It's a very treatment-centric model. When your loved one has a substance use disorder, in many cases, our first thought is access, linkage to treatment. The problem is, I'm being let out of that treatment center after 30 days with a brain that's effectively still addicted. I'm being let out with no recovery capital, and I'm being expected to maintain my recovery. And by no recovery capital, what I mean is all the recovery capital is stuck in the treatment center. So think about it like this. Treatment centers are like Fort Knox for recovery capital, right? It's like, it's where all of the recovery capital is. You've got educated counselors, and you've got peer support, and you've got nutrition, and you've got structure to your day, and you've got everything that you need, all of those ingredients all in one place. And it should be no surprise that people tend to thrive in that environment. People tend to even be abstinent in that environment. Recovery flourishes in that environment. The problem is not that there's anything wrong with treatment, other than the fact that it's 30 days and it's insufficient. And on day 31, we're letting people out who have addicted brains, who don't have the resources that they need. And so the problem is that that recovery capital gets stuck in treatment centers and people leave them behind. And so where we want to go, the future, is what we call recovery-oriented systems of care. And what you notice is the focal point of the very first approach, the war on drugs approach, was we're going to address addiction in a jail cell. And it didn't work. And the focal point of the second approach was we're going to address addiction in a treatment center. And I want to suggest to you that north of 100,000 people dying in a calendar year is not working. Where we want to go is towards addressing addiction right at home where people live. So instead of going to treatment for 30 days, accessing a bunch of recovery capital, and then on day 31, coming home with an addicted brain and no help, instead, what we want to do is drive the resources into communities where people live, where people are going to live for the long term as they go through this process of recovery, right? And you notice that treatment is still an incredibly, incredibly important feature of a ROSC, a recovery-oriented system of care. Just like I don't want people to think that I'm bad-mouthing abstinence. I'm not bad-mouthing inpatient treatment at all. I think it was probably necessary for me, probably saved my life. It's a very important element. It's just not the focal point. It's not our front line. Instead of thinking of recovery capital and all of that as aftercare, it's the focal point first. And then if that isn't sufficient, people may need access to treatment, to peer support, to all of these other things. I'm going to skip ahead to my analogy for this. I told you I got a job early in recovery that I didn't deserve, and that may have led you to believe that it was a super fancy job, but it really wasn't. At the time, I told people I was doing tobacco research, but really what I was doing was digging holes, and the scientists were doing tobacco research. And I was a suburban kid. I'd never been on a farm. I'd never been in a greenhouse. And the first thing I noticed about the greenhouse is it was this climate-controlled environment where the plants would just absolutely thrive. And they got steady access to air and to water and to sunlight and to nutrients, and they would shoot up. And when they reached a sufficient level of maturation, we would load the trays onto a trailer and we would drive them out to the field and we'd set the tobacco. And if we set it in good soil, it would transplant pretty effortlessly and thrive. And if we, set it in bad soil where there was low-lying area or too much rainwater or whatever, it would wilt and it would die. So this is my analogy for the difference between treatment and recovery. Treatment's like a greenhouse. Treatment is a climate-controlled environment for recovery, where we, the plants, have access to all the nutrients, all the recovery capital in the world. It's no wonder that we grow and thrive and we shoot up. The problem is, when we're nowhere near sufficiently matured, I don't want that to sound like I'm infantilizing people who use drugs. I just mean in the sense that the brain isn't sufficiently sort of repaired. And yet we send people out of treatment with minimal resources, minimal support, and just expect them to figure it out. So what are some of the things, the ingredients for recovery capital that are so important to build? I would probably argue that the single most important is connection. And you've heard a lot of different thinkers and authors describe this in different ways, but my favorite way of grounding this is in the brain, because I believe so wholeheartedly that understanding addiction in the brain helps us understand recovery in the brain. This is an article that was published in a peer-reviewed journal about 13 years ago. And essentially what the article talks about is pro-social interaction. When you and I sit across from each other at the restaurant and we share a meal and share an interaction and look each other in the eye, that actually leads not just to a spike in dopamine, not just to a dopaminergic effect, but it upregulates dopamine. In other words, social interactions are organic medicine to our addicted brains. And the thing that I find so ironic about that is it sure seems like we've designed a society and a culture where we want to disengage from people who use drugs. We prevent social interaction with people who use drugs at every turn, right? We disenfranchise people who use drugs. We shove them to the margins. And the one thing that their brains need more than anything is connectedness, is belongingness, right? And that's why one of our ethos, it's not really one of our core values. In many ways, it is our core value at Voices of Hope, that we value all pathways. I'm not the king of recovery, and I don't sit up on top of my throne telling people whose recovery is good and whose recovery is bad, and whose kids should be proud of them and whose kids shouldn't be proud of them. I just want people to be happier, and I just want people to be healthier, and I want my community to be healthier, and I want fewer people getting arrested, and I want fewer people experiencing homelessness, and these are the things that I care about. And that's what it means to support all pathways to recovery. So I put this up here probably as a shameless plug for Voices, because I'm very proud, but also to show you what it looks like to focus on assets and not abstinence. Because at Voices of Hope, we're not evaluating our programs based on whether or not a person is abstinent as a result of participation in our program. We're evaluating our programs based on the extent to which we're building recovery capital for the people in need. Because we recognize that many of those folks may still be in process. They may be early in the stages of change, early in process, and the provision of resources at that point may not be enough for them to achieve abstinence or whatever it is. It doesn't mean it isn't an important relationship. It doesn't mean we aren't building recovery capital and reducing attendant harm all at the same time. And what our Recovery Community Center does is it serves as that transplant. So if I can, I'm sorry I jump slides a lot, but it's helpful to me. If you think about trying to transplant, right, all those resources, all that recovery capital into a community to surround someone with the things that they need, that's what we're describing here. Taking all the ingredients that have made people so successful in treatment, and instead of making them short-term and intensive, making them long-term and extensive at a community center where people can access them on a daily, weekly basis, whatever works for them. Okay, with my last, what do I have? 3 minutes. I'm going to make a quick case to connect harm reduction and recovery capital, because you may have heard both concepts, but I think they're related in a really, really important way. And the best way for me to share this with you is by using the stages of change. So just in case you all aren't familiar with this, Prochaska and DiClemente said in order to change any behavior, in order to quit smoking or lose weight or whatever it is, you have to progress through these particular stages. And so pre-contemplation says, I don't have a problem. That's denial or ambivalence. Contemplation is like, I'm beginning to toy with the idea that my third DUI isn't normal, but I'm not convinced I have a problem. Preparation is when I'm equipping to do something about it. Action, as it suggests, is when I take action. And maintenance would be like recovery, maintaining that change. And the reason this is so helpful is because it helps us think about the limitations of our current treatment approach and the limitations of an abstinence-only approach. So let's imagine that we can locate all 23 million people who have substance use disorder in the United States somewhere on this spectrum. Or in your individual cases, you can imagine we can locate every single person who's addicted in your communities somewhere on this spectrum, right? They're all in different stages of change. Under our current model that says you have to be abstinent first, you have to be ready and willing and able to be abstinent today, we're only effective with folks right here. And we say things like, come back when you're ready. We say, come back when you're willing. We say he or she needs to do more research. They haven't suffered enough. And that's the primary fault of prioritizing abstinence above recovery. What harm reduction allows us to do, the reason harm reduction is so advantageous beyond the obvious value of reducing harm, is that it allows for engagement. It prioritizes connection above abstinence. And so it says, instead of waiting for someone who may or may not ever arrive at a place where they're ready or willing to become abstinent, instead, we're going to pursue them aggressively right now. And we're going to connect with them right now. And we're going to do whatever it is that we can to support them. And many people, harm reduction literally allows you to effectively engage with someone who's in pre-contemplation. And what that means is those people who you've worked with before, who have substance use disorder very clearly, but really genuinely are in denial and do not believe that they have a problem. And you know how maddening those clients can be, how distressing that can be to work with. Well, it's really only distressing if your only goal is abstinence. If your goal is to help understand what needs they have and how you can reduce harm now and how you can build capital and connect to assets now, you need not be adversarial. It need not be at odds, right? And what harm reduction allows us to do is start building recovery capital for people. So instead of waiting until a person becomes able and willing for abstinence, what we do is we start building the capital for them now, so that, let's say down the road they decide they want some type of change. Now they have the resources that they need to help sustain their change, right? As opposed to recklessly going to try to find it after they've gone to treatment. Harm reduction allows for engagement. And this is my favorite way to kind of drive home this point. So according to the National Survey on Drug Use and Health, there's always a treatment gap. So 23 million people in the United States have an SUD, but only 2.3 million access treatment. And so we talk about the treatment gap. 90% of people who need treatment aren't getting it. And what's interesting is when you do a deeper dive on that data and you ask those 90% who stand in the gap why they didn't receive treatment last year, the majority of them tell you it's because they either don't think they needed treatment or they didn't want treatment. Right? And that creates a problem for us because under this model, those 90%, they're not engaged in care. We're saying, oh, you're not ready for treatment for abstinence, then go suffer. Come back when you're ready, right? The value of harm reduction is that it allows us to meet people where they are. And my favorite example of this, I was looking at some demographics of a recovery community organization in Florida that does some harm reduction work. And it's just a random tidbit that I pulled out, but I noticed that in their demographic data, 87% of their participants had used a substance in the past month. And it made me chuckle to myself because to the untrained eye, I think an outsider might look at that and go, wow, that program sucks, right? Everybody's using drugs. Obviously, it's not effective. It's not helping anybody. Well, you only believe that if you can only myopically evaluate outcomes in terms of abstinence. But what we know is those 87% are the folks who exist in the gap. Those are the folks who otherwise were not being engaged in any kind of treatment, in any kind of care. We weren't able to reduce the harms associated with their drug use. We weren't able to begin building capital for them. And it's precisely because these organizations exist that have a harm reduction orientation that those 87% went there to experience belongingness, to experience connection, to experience a place where they're accepted as they are as people who use drugs, So it allows us to engage the otherwise unengaged, the majority of people who have substance use disorder. And I know I'm up against time. So I'll stop there with some key takeaways and just say recovery capital is so important. Recovery capital is important because it can preclude the need for treatment, which is incredibly important, especially when resources for treatment are scarce. But also for people who go to treatment. It's an incredibly important essential piece, not something we should start thinking about after we go to treatment. It's not like we should exhale and take a breath when someone arrives at the front door of treatment. They have a chronic disorder, right? So there needs to be chronic disease management in place. And harm reduction and recovery capital are not at odds. It always breaks my heart that sometimes people cast harm reduction as giving up on abstinence. Sometimes that's how people will frame it. Well, harm reduction is what we do for the frequent flyers, for the people, whatever stigmatized term we want to use. And the reality is I see it exactly the opposite. This attitude right here is giving up on people. To me, harm reduction isn't giving up on people. It's doing the opposite. It's reaching out to people and saying, you're worthy as you are. You're worthy of help. You're worthy of care, right as you are. So thank you all so much. I'll put up my email in case you'd like to send me questions. I'm happy to take questions now for as long as I'm able.
Alex, thank you so much. Again, we're honored for you to join us on your recovery birthday. Thank you for being here. I really appreciate how you weave your own experience as well as other real life experiences into your presentation. I think it really helps to ground us and remind us of the reality of this ongoing crisis and the impact that this work has on individual lives and communities. There are, I think, a few questions here. We're running low on time, so I'm going to try to maybe hit one or two if we can. So I did want to, you talked a lot about recovery capital and explained and helped walk through what that looks like and what those different elements are. I know in our work at the state, we do a lot of tracking and assessing and measuring recovery capital so we can ensure that we can see how folks are progressing through their treatment. Any suggestions for those on the call around how to properly do that in their own organizations and how they can ensure that folks are progressing? Are there particular tools you may recommend or models you may recommend as far as assessing or measuring recovery capital?
That is a great question. And if you'd be, whoever's asking that, if you'd be willing to shoot me an email, I can send you some stuff, but there's a lot, actually. It can kind of be overwhelming. I'm also really honored to say I'm working with some researchers from the Center on Drug and Alcohol Research on non-abstinent recovery outcomes. So trying to look at what are the other outcomes that we care about. And as a part of doing that work, I did a little bit of a literature review looking at kind of the existing evaluation tools for recovery capital, and there are way more than I realized, and many of them have been developed within the last 3 or 5 years. Lots of validated scales, some brief validated scales that have more clinical utility, more clinical application. So I'd be happy to send you some of that, but there are a lot, and it's really an emerging science is really what I should say, is we're still working on testing those scales and trying to arrive at, how do you really operationalize some of those more abstract dimensions of recovery, like like spirituality or like whatever it is. Some of those are pretty hard to nail down.
Thanks, Alex. And another question, sometimes many of our community programs and initiatives operate, unfortunately, in silos. Do you have any recommendations for how our attendees and their respective organizations can better collaborate across the varying community partners? So between treatment providers, recovery community centers, faith-based organizations, employers even, how can they best make these connections?
That's such a good question, and I'm panicking a little bit because I recognize that I don't have a good answer for this question.
It's a hard one. It's a loaded one for sure.
It is. And I guess I'm not going to be answering your question, but I would just acknowledge the importance of that collaboration. And in the context of what we've just talked about, if addiction is this chronic disorder and if recovery is this process, and it speaks to the need for all of to be unsiloed. It speaks to the need for there not to be silos and for there instead to be a continuum of care. So I think mostly I'm just mansplaining and agreeing with you, but I do.
Okay, last question. And you can also follow up by email if you don't have time, but any suggestions with regard to incorporating recovery capital as a component of drug-free workplace policies?
It's a great question. I think, one of the things we say is in order to provide people resources, in order to provide people opportunities, in order to provide second chances, we want to know that people are worthy. And I think my biggest issue, and just one of the points I wanted to drive home today, is that whether or not a person is using drugs shouldn't be the indication of whether or not they're worthy, because there are many of us who try and fail at the same time. We're trying so hard not to use, but we are. And then somehow 5 years later, we're trying so hard to use and we're not. And the difference isn't how hard we try. It's not a moral issue. So I think it just goes back to that for me. That's the importance of having some other measures, because then you can actually track progress in a process. You can actually track a nonlinear process rather than just saying you're only worthy if you're absent. And that's all that matters.
Thank you so much. There are a couple of questions in the chat for you. So if you have some time to stick around, Alex, and address those, that would be great. Or feel free to follow up with folks by email. You can send us responses and we can get those responses back out. But we so appreciate, again, you joining us today. Really appreciate your amazing presentation. And thank you again for your time. All right, so I'm going to turn it back over to Nikki, who is going to be wrapping us up for the day.
Great. Thank you, Dr. Allen, and everybody who presented today. It's been a great session. We're almost through it. So I'm going to invite Diana to join me. We're just going to go through the CEU process really quickly on how we can claim that. So I'm going to share screen and we'll get Diana on and we'll walk you through that real quickly. Here comes Diana. Thank you.
Thank you for joining us today. I would like to take just a moment to share how you will receive your CE credits for today's training. You will need to have attended at least 90% of today's training. By September 27th, you will receive a link through email that will let you access the evaluation and your certificate. The website is listed there. It will be in your email, and only those who have attended 90% of today's session will be eligible for a certificate in CEUs. Attendees will log into MTS, the website you're sent, with your email address that you use to register for this conference. We stress that because your email address is your unique identifier through the company we use to receive your CE credits. You must complete a session evaluation, which is very brief, and then it will take you directly to your certificate. You are responsible for printing your own certificate, and if you have any questions or need help, please feel free to email us at the address on the screen. It will also be listed on the email as we send it on the 27th. Thank you.
Great. Thank you, Diana. And I will say that we had 2 hours of CEU approved for today's event. So you'll be able to claim those. And then I wanted just to quickly highlight our upcoming sessions that we have. So our next session is going to be on September the 29th at 11:30 a.m. This is going to be provided by Miriam Stillman, and it's going to cover the power of P, moving from ACEs to PACEs in SUD and recovery services. And then our next training after that will be October the 19th at 1:30 with Dr. Michelle Loftwall from the University of Kentucky. And she's going to cover what families and communities should know about opioid use disorder and medication treatment. So these, again, are free registration, free training. We do have CEUs pending for each of these training as well. So we also wanted to make sure that we're doing these trainings to benefit our partners out in the community. So we want to provide trainings that benefit you and are of interest to you. So if you have any particular training interest, please feel free to email us at KentuckySchoolVirtual@ky.gov. And then we also have an opportunity for you all to present as well. So we have a call for presentations that has a rolling application. So we're going to drop that link to you in the Q&A. It's a ready up link where you can go in there and submit your presentation for review. So we'd love to hear from you. We're doing this for you, and we want to make sure that we're meeting your needs. So before we leave today, I have just one more thing to share with us, and this is the Kentucky School Virtual Learning Series awards. So I have a quick little video here from Mike Berry that we're going to play that kind of announces who our awardees were for the day. So give me just a moment.
CEO of PAR, People Advocating Recovery, and now the board president. In keeping with the Kentucky school tradition of honoring outstanding individuals and organizations in our communities, we're going to offer a virtual awards ceremony this year. These awards acknowledge and honor individuals and organizations that have excelled in harm reduction services, prevention services, recovery support services, and treatment services. The nominees should have shown outstanding dedication, innovation, impact, and effectiveness in their respective areas. making significant contributions to improving the lives of individuals affected by substance use and related issues. Our first award is Excellence in Harm Reduction Services Award. This award recognizes an individual or organization that has made a remarkable impact at the community level through harm reduction initiatives. Nominees in this category have shown outstanding dedication to addressing the needs of their local communities affected by substance use disorders. They have implemented community-based harm reduction programs, engaged in outreach efforts, provided essential services and resources, and are collaborated with local stakeholders to create sustainable and effective solutions. Their work has significantly reduced the harms associated with substance use and improved the overall well-being of the community. Our award winner is Brandon Fitch, Four Rivers Behavioral Health Turning Point Program Manager. As the program director for Four Rivers Behavioral Health Turning Point Recovery Community Center in Paducah, Brandon has excelled in engaging the entire recovery community in harm reduction efforts, oftentimes leading a coalition of area resource providers to meet emerging needs in the community. In just the last year, Brandon has established overdose quick response teams in 7 counties. He's also installed emergency Narcan boxes throughout the 9 westernmost counties in the Commonwealth in locations like libraries, county courthouses, police stations, healthcare facilities, and retail spaces, including the many McDonald's locations in the area. Congratulations. Our second award, the Michael Lothar Excellence in Prevention Service Award. This award recognizes an individual or organization that has demonstrated exceptional commitment and effectiveness in substance use prevention efforts. Nominees in this category have implemented evidence-based prevention programs, developed innovative strategies, and effectively engaged with communities to reduce the onset and prevalence of substance use. Their work may include educational campaigns, community mobilization initiatives, policy advocacy, and the promotion of protective factors to prevent substance use among individuals, especially youth. Their efforts have significantly contributed to creating healthier and safer communities. The award goes to Amy Hutchinson, Life Skills Regional Prevention Center Manager. Ms. Hutchinson has worked in the field of prevention for 21 years, and during this time spent time writing, obtaining, and overseeing numerous grants, guiding regional coalition development, and most recently, the operations of an expanding regional prevention center, RPC, in South Central Kentucky. In her role as manager of the Life Skills RPC, she oversees initiatives and staff working in a 10-county area. The RPC actively participates in more than 20 coalitions and boards. It's impossible to highlight all of Ms. Hutchinson's accomplishments. Our congratulations go out to you. And a little side note on this next award. A number of years ago, I was honored that Kentucky School created an award in my name, and this is the first time we get to present it to somebody. This is the Mike Berry Excellence in Recovery Support Provision Award. This award honors an individual or organization who has shown outstanding leadership and innovation in the field of substance use recovery support. Nominees in this category have made significant contributions to developing and implementing effective recovery support programs and initiatives. Their leadership may involve creating inclusive and supporting environments, advocating for recovery-informed policies, fostering collaborations among diverse stakeholders, and promoting the use of evidence-based practices. Their visionary approach has positively impacted the lives of individuals in recovery and strengthen the recovery support infrastructure in their communities. The award goes to Edgewater Recovery Center, LLC. Edgewater Recovery Center has created a partnership with St. Clair Hospital to show the medical community and the public how beneficial the value of peer support is by having peer support stationed in the emergency department. Behavioral health and making rounds to other clients that identify they have a need for substance use or mental health support. They have created a response team that operates on a rotation to regularly bring information and support to clients in the behavioral health unit, even if it comes in the form of a visit on a visitation day. The same team remains on to call to respond to overdoses at the ER, to offer experience and treatment options in what can be a very frightening time. This program has proved both beneficial in aiding individuals to find recovery resources, treatment, 12-step meetings, etc., literature, but also in harm reduction efforts, the needle exchange programs, Narcan, fentanyl, test strips, and many other services. Our congratulations go out to the Edgewater Recovery Center. Next award is the Robert Strauss Excellent in Treatment Service Provision Award. This award recognizes an individual or organization that has demonstrated exceptional dedication, expertise, and success in the field of substance use treatment. The recipient has made significant contributions to the field and has achieved notable outcomes in helping individuals overcome substance use disorders. The award goes to Stacy Sylvester, the REACH program. Stacy Sylvester owns and operates the REACH program in both Bullitt and Nelson counties in Kentucky. Stacy is a licensed clinical alcohol and drug counselor and certified social worker and clinical service supervisor. She primarily provides substance abuse services for men, women, and adolescents in our Bullitt and Nelson County locations. Stacy is certified in anger management, adolescent community reinforcement approach, helping men recover, seeking safety, and several other evidence-based programs. In Bullitt County, Stacy works with the youth in the schools. She also works with the Families Moving Beyond Abuse Family Court drug program run by Judge Elise Spainhour. Stacy also works with the Juvenile Drug Court program run by Jennifer Porter and works with the Adult Drug Court program with Judge Rodney Burris. Stacy and her team do amazing work and produce great and lasting results. Stacy also works inside the Bullitt County Detention Center to provide substance abuse treatment. And our congratulations this year go out to all of our winners. Thank you for the hard work that you've done.
Wonderful. Thank you to all of our winners. We are excited that we're able to celebrate you, and we'll be delivering awards in person to each of you in the coming weeks. I would also like to say thank you to all of our partners and community members who nominated folks for the awards. So without you, we couldn't be doing this. And I would like to say, before I hand it off to Dr. Allen for her final words, just on behalf of the team, we thank you for your participation today, to all of our speakers for their time and effort. This has been a great kickoff event, and we look forward to bringing you future sessions.
Thank you, Nikki. You took the words right out of my mouth. I am so appreciative of all that were able to join our kickoff session today. Thank you to our incredible team at the department who have put in so much hard work to make this day happen. Thank you to our interpreters that were able to join as well. Our presenters who were absolutely amazing. I think they're off the call by now, but so grateful for the amazing work they do and for what they were able to, the knowledge they were able to impart on us today. Again, thank you for joining. We really look forward to bringing you more in the future. We look forward to having in-person Kentucky School again in the near future as well. So stay connected with us. Please reach out if you have any questions to our Kentucky School email, which I know has been dropped a few times, but maybe we can drop it one more time just in case people have questions about how to get their CEUs, or just about, you know, what's going on with Kentucky School and where we see it going. So we look forward to hearing from you all. We look forward to seeing additional submissions and training opportunities that you all want to see from us in the future. Really excited about what's to come for Kentucky School. Have a great rest of the day, everyone, and thank you again.
Thank you.